All right. Good day, everyone. This is the Concept Academy webinar in Step 2 Neurology. So, all we need from you basically is just to be well relaxed, get the point, get the gist, and just move on. You see, just as I used to tell us, the best material to use to prepare for your step 2 is still your first aid. If you do not have first aid, try to go and get one. It helps you far beyond just passing the exam. At least it gives you the ideas on the things that are quite important in practice in US. Then there are some aspects of this first aid neurology, just like any other system too, that I might need to flip to the step 1 for you to get it. Now, the whole idea is not for you to sit down and just be cramming things. You will not really enjoy them like that. So all you need to do is to pick the important point, pick it, and just move on. It might just be one statement and move on. We have 107 pages here. The questions might not be up to 15 questions. So why do you want to kill yourself? So just be lenient on yourself. You don't need to be a neurologist. All you need to do is just to get the gist, pick the idea. You cannot become a pro in it overnight. So please just relax and let's make the journey quite easy on ourselves. So this is the neurology. These are the things they expect. If you look at them, they are even basic points that you might have been exposed to in step 1. So another thing again is that you can use your step 1 material to prepare for step 2 basically. So all the points, they are in it. They are actually in it. It's just that know the way they write them. So but you can use the step 1 material to prepare for the step 2. So if you look at the step 2 and you are like, this thing is looking too cumbersome for me, go and pick the one and just flip through it. If you can still remember them, that's more than enough, because everything here is still in one. So this is clinical neuroanatomy. What they just want us to remind ourselves coming to the exam is just this diagram, which we know already. So this is just the diagram they want us to remember. And this is the same diagram here. So this is the same diagram here. You just want to remind yourself where is the central sulcus. So that in case they give the diagram, you just be like, okay, the region that is actually in front of it is going to be the primary motor area, while the area behind it is going to be the primary somatosensory area. Then the area that is abutting the primary motor area at the front, premotor cortex. So you can even guess the function of the premotor cortex basically. So this is where the planning, anytime motor activity wants to take place, this is where the planning and the likes will occur. So that's why they call it premotor cortex. So the information will now be sent to the primary motor cortex. Then the information will be picked by all the corticospinal tracts that are here, cortico, bulbar and all manner of stuff. They will just move down and go and execute it. So to modulate it is when the duty is actually the duty of the basal ganglia. So you have a cup right before you. You want to reach out to that cup. The ability to reach out for the hand to actually get to the cup, at least for the stretching to occur, the planning, premotor, primary motor will execute it. For the hand not to overshoot the cup, that is the duty of the basal ganglia, to modulate it, to ensure that whatsoever you want to carry out is carried out. So just for you to have an idea, not for you to be looking at it like a neuroanatomist. You don't need that. Trust me. You may not even get any question on this. You may, I say. I never thought they give you any question on this. It might just be step one knowledge that you are going to just use and be like, okay, this is what's going on here. So don't kill yourself. Then the primary somatosensory area, just like the way you look at motor. So the ability to actually say that, okay, or to sense, that is going to be determined. I mean, it's actually pegged on this primary somatosensory area. So basically, this is like the sensory area. This is the motor area. All right, we now have what we call the somatosensory association cortex. This is actually the somatosensory association cortex. So what it does basically, all the 2-point discrimination, stereognosis, which is inability to actually, if at all there is a lesion there, inability to recognize an object only through by touch. For me to touch you, to put a pen on your hand, you know, you feel that pen while the eyes are closed, and you now say, okay, this is actually a pen. Oh, this is a cup, just by touching it. So it's actually the duty of the somatosensory association cortex. So if you look at it, it goes a step beyond just sensing. It's more of identification, identifying. So you can look at it like that if you wish. So that's for you don't need to cram it. So nothing more, just for you to know 2-point discrimination. What is 2-point discrimination? You pick the forceps, you open the forceps, you now use the mouth of the forceps to actually touch the patient. You know, the two what do you call it of the forceps will be touching the patient at the same time. For the patient to be able to say that I'm actually, two things are touching me, not perceiving it as one. So that is the duty of somatosensory association cortex. Then if the question says the patient, they trace something on the patient's hand, and the patient can identify that, okay, this is letter A, this is letter B, this is number 5, this is number 6. It shows that the somatosensory association cortex is actually working well. So just for you to have an idea, it doesn't mean you should see that if they are looking big for you, just ignore. Make the journey quite helpful. Easy. Then we also have some conditions that you can peg basically on what do we call it? Auditory association cortex. So it's actually overlapping with the somatosensory association cortex. So just this area where my cursor is. So if I thought there is a lesion there, the patient can have Jesma syndrome and also can have neglect syndrome, or you call it hemispatial neglect syndrome. Now, this area is very important for the exam. Just this, guys. So the way you will look at it is this. You have two things to diagnose in the exam, and I will try to show you. I do not want to go into detail of all this stuff because they are just step one, which I know you know already. So you have hemi neglect. So this is neglect. We write letter N, and this is Jesma. We just write letter G. So neglect, just draw a line like this and put it on non-dominant, NN. So Jesman is going to be on the dominant hemisphere. So which means that you need to first of all identify what is the dominant hemisphere in that question, which one is the non-dominant hemisphere. All right. Basically, the dominant hemisphere is going to be on the left. That's just it, whether the patient is left-handed or right-handed. It's just very few number of people that have their dominant hemisphere on the right. So don't go and be using that way of looking at it, that if the patient is right-handed or left-handed, whether right-handed or left-handed in the exam, just look at it that dominant hemisphere is on the left. All right. So if the dominant hemisphere is on the left, So if I thought they now say that there is a lesion on that left hemisphere, then you know that the patient would develop what we call the Gerstmann syndrome. If the question says the patient is having a lesion on the right cerebral hemisphere, so that is going to be the non-dominant, the patient will develop the neglect syndrome. Now, in my step one, so what we did actually is just to show the video of the neglect, how so you will appreciate it in real life. So the way they look, which I will advise you to do, the same thing for the Gerstmann. For the Gerstmann, they cannot rise spontaneously by themselves, but they can copy. They cannot do simple arithmetic, 2 plus 2, 2 plus 3. They can't do it a calculator. So finger agnosia, they cannot really identify their finger. Oh, this is index, this is little, this is middle, this is ring. They can't do all those stuffs. Then left to right disorientation. They do not know their left from their right. So all these things, they will put them in question. You just say this is Gerstmann. Now, this is not the question they will now write. Now, see, where do you think the patient is having the lesion? So once you see these guys, a gravia, a calculia, finger agnosia, left-right disorientation. So you just say, okay, this is actually on the dominant. So if it's on the dominant, you just look at that question. You say this is going to be on the left. So if it's on the left, so you just look at the question and pick left cerebral hemisphere, and that's all. So that's how, because in the exam they will put left, right, left, right, left, right. They will just be putting it there. So your ability to remember the simple analogy we just try to do here, it makes a lot of sense. All right, so we don't have much to do here. So just to remind ourselves, not that we are teaching it. Then we also have what we call the frontal eye field. Your ability to perform conjugate eye movement wherever you are. The two eyes can look to the left, the two eyes can look to the right. It's actually mediated by one of the things that mediate at the cortical level is the frontal eye field. So that's just what you want to know. So if I thought they now say that there is a lesion on the frontal eye field, you are going to have two, basically, one on the right, one on the left. So what you see is that the two eyes will actually be looking, they will deviate towards the side of the lesion. So if the two eyes are looking to the left, that is where the lesion is. If the two eyes are looking to the right, that shows that the lesion is actually on the right cerebral hemisphere. So you imagine this is the eye, these are the eyes. The two eyes are now looking here and here. Can you see? So you say this is actually, if this is right, this is left, so then the lesion is on the right cerebral hemisphere. So you just check the option and pick right, frontal eye field. All right, lesion. So that's just what you want to know. They will can just show the picture and just pick it. So it's more of, you don't even need to read for step 2 before you answer that kind of question. Then prefrontal cortex. Prefrontal cortex, basically, all of us here know it. Disinhibition, disorientation, poor judgment. If I thought there is a lesion in it, so we perform inhibition. We experience inhibition. This is someone that is moving on the street and see opposite sex. That is, the person now want to touch the opposite sex and be like, oh sister, someone is calling you. How come the person does not just spank the that opposite sex at the bum? So everyone will. So we are actually inhibited because our brain will learn this not right. The patient is going, or this person is going on the street and feel pressed to actually pull, and the person will look at it and be like, no, I can't stand beside the street here and be pulling. It doesn't make sense. That is inhibition. The person wants to urinate and does not, he is feeling pressed but does not pee on himself. That is going to be inhibition. So inhibition is actually, once you see that in question, you know that this is actually helped or executed by the or supervised by the prefrontal cortex. So if you now read the question that is showing that the patient is having disinhibition, then definitely likely the patient is having a lesion in the prefrontal cortex. So the question is saying the patient is touching opposite sex inappropriately, is doing this, is doing that. Just know there is prefrontal cortex lesion here. All right, then it's also helped in the elimination of what we call the primitive reflexes. So all those primitive reflexes we are going to be looking at in pediatrics. You don't need to cram them. So it's not that we now get there and now be like, okay, I need to cram them. No, that's a lie. You don't need to cram any shingbind there. So just to pick one or 2 points down, and those points you already know them, just to remind yourself and be rest assured that they won't go beyond that. All right, all those reflexes after a while, definitely they will disappear. They disappear because there is now proper myelination of the upper motor neurons, and also the proper development of the prefrontal cortex. So if at all there is a lesion in the prefrontal cortex, so you are most likely going to see some of the primitive reflexes recurring. So, and that's just with respect to this area. Just pick it like that and nothing much. Poor judgment also, if at all there is a lesion here, I ask you what's the difference between a car and a bicycle. The ability to say one of them is actually having 4 tires, the other one is having 2. One, it can carry more passengers, the other one cannot. One can run faster, the other one cannot. This one is using fuel, this one does not. This one is covered, so if at all, you can use this one when it's quite sunny, it's rainy, and you'll be comfortable inside it. All those judgments, they are mediated by the prefrontal cortex. So if at all the question says simple, they just ask the patient that, okay, what's different between this, and the patient cannot really say. There is most likely going to be likely the patient is having a lesion affecting the prefrontal cortex. So you just look at it briefly, not nothing much. Look at this, what do we call it, the Broca area. With respect to the Broca area, this is where speech is being produced from. At least it's important. It's important in speech production and the likes. So if at all there is a lesion affecting the Broca area, the patient will not be able to talk. So you now imagine a patient that is having Broca area lesion or something affecting the cerebral hemisphere that is now affecting the Broca area. So you realize that the patient is going to be a bit muted. So it's going to be muted and will not really be able to talk. So because they say the speech is significantly reduced. So you can imagine how the question will go. All right, where is this Broca area? You usually see it. If they ask you where is it, you see it in the dominant hemisphere, which is on the left. So this will be found on the left hemisphere. Can you see? Left hemisphere. All those important areas, Broca area, Wernicke area, you see them on the left cerebral hemisphere. So if this can be a clincher for you to know which cerebral hemisphere is affected. So if you check the question and you realize that the patient is having Broca aphasia, so definitely the lesion is on the left. So all your answers will be related to left. So, and that's that. Once you see this area, whether Broca or Wernicke is affected, you just navigate your way down to the left. So because they are located at the left. We also have aquate fasciculus, which is connecting Broca area to the Wernicke area. So this helps with repetition. So anytime you read a question that now say the patient cannot repeat, just know the aquate fasciculus is affected. I say cerebral cortex, and the patient can respond cerebral cortex. Regions. So all those ability to repeat, they are mediated by this aquate fasciculus. So if the patient cannot repeat, aquate fasciculus is affected. So the kind of aphasia that affect this area, you call it conduction. This is what you know, conduction aphasia. Wernicke, they talk, but the ability to talk and understand whatsoever the patient is saying it shows that the Wernicke is actually for them to make sense out of their production. So it's you peg it on Wernicke. All right, I'm talking now. I can talk. Or just saying all manner of stuff. But if I'm not making any sense out of whatsoever, or you look at whatsoever I'm saying, you can't even make any sense out of it. Something is wrong with my Wernicke. Then, do you get it? So Wernicke area makes the patient to be able to talk and make sense. So if I told you it's now Wernicke, a lesion affecting the Wernicke area, definitely the patient will be talking but will not make sense. So they talk and just have been saying rubbish. So that's just this. This is what you know. It's not that maybe it's what you don't know. So now I want to differentiate for you briefly before I leave this area. What's the difference between Broca aphasia, Wernicke aphasia, then transcortical? So anytime they mention this particular area, whether Broca or Wernicke, they now add aphasia to it. That area is affected. The arcuate fasciculus is also affected. So if they say Broca aphasia, the Broca area is affected, the arcuate fasciculus is also, so it shows that the patient will not be able to produce speech spontaneously, will also not be able to repeat. Can you see? Will not be able to repeat. So there will be impaired repetition. So the same thing here, the patient will be saying rubbish, and the patient will also not be able to repeat. There is impaired repetition in Wernicke aphasia and Wernicke aphasia and Broca aphasia. However, if you check the question, the only thing you see in the question is that the patient cannot produce sound, or the patient is just talking rubbish. Repetition is intact in that patient. You call that transcortical. So if it is with production, you call it transcortical motor aphasia. If it is with Wernicke, you call it transcortical sensory aphasia. And that's that. So in transcortical, arcuate fasciculus is not affected. Basically, so I'm going to leave that one there. So that's just what you remind. You just need to remind yourself and know that in the exam, whether they mention dominant or non-dominant hemisphere, or they mention the handedness, just know that the dominant hemisphere of that patient is on the left. So that's just what I'm supposed to write here and for you to know. This is another area that they are also going to set question on, which you don't need to give yourself headache. Just look at it simply. But immediately you start putting a lot of efficacy into it, like, yeah, it's this. You will be complicating the matter. All right. So this is the, we call it homunculus. All right. There is no one here that will say that I do not know something called, even though you might have forgotten. So homunculus. All right, so it's more or less just giving you an impression of the representation of the whole body on the hemisphere. So now, the way you will look at it is this. You will look at, this is the, let me say this is the right cerebral hemisphere, this is the left. It's more or less like they call it, they cut it like this, so that you'll be able to see each of them like separately. All right, so now look at this middle part of it, or media part of it. What you see, this is the media part of this one, right? This is the media part of the left, and this is the lateral portion of it. This is the lateral portion of the one on the right. All right, so this media part of each of the cerebral hemisphere, the part of the body that you see that is represented here is actually the lower extremities. All right, so you are seeing the trunk, the hip, the knee, the ankle, the toes. They are actually the lower limbs. You can see the lower limbs. You can see the lower limbs here. All right, so that's that. So if I thought they now give you a question that the patient is having weakness on the left lower extremity, apart from the weakness, they now add sensory to it. the patient is also having sensory impairment on the left lower extremity. If you look at it, I mentioned motor. I now add sensory to it. Please, I want you to follow the gist. Like, very interesting. I mentioned motor is weakness. I now add sensory to it. So just know, and we now ask yourself that, is it localized to one particular part of the body? And you're like, yeah, it's just only to the leg, lower extremity, left lower extremity. If it's the left lower extremity, we talk about crossing. Crossing will have occurred. So the lesion is going to be on the right. So this is where the lesion is. The question they will ask in the exam is, which artery is affected? The answer is right anterior cerebral artery. That's all. That's all. It must be motor and sensory manifestation that you can't talk about pure motor. It's not pure motor. So you just say motor and sensory, just say anterior cerebral artery. So if it's on the opposite limb, so let me say right lower extremity, the patient is having weakness and sensory impairment, then the answer is going to be the left anterior cerebral artery. All right, this is for the leg. I just call it L. So this area here, if you look at it, you have the arm and you have the face. I just look at it like this: laugh, arms, face. So if the question says this patient is having something related to the arm, weakness on the arm, sensory impairment on the arm, not only the arm, forearm, all those stuff, all of them are there. So just no upper extremity, but we call it hey, you can look at it like that if you wish. If you want to change it to you, that's fine. So then something related to the face. Something related to the face. All right, once you start seeing something like this, two of them, both the arm and the face, they are there, just know you are dealing with the cortical lesion. All right, so if it's the cortical lesion, so then the question they will ask is that which vessel is affected. The answer will be middle cerebral artery. It will be arm, face, arm, face. And when you check the question, that's what you see. There, arm, face, arm, face. So it will be there. All right, so you can correlate it to just check, is it on the right part or the left part, for you to know which one is which. And that's that. So that's just the homunculus here. Now, the last thing I want to say is, if the side that is affected is the left cerebral hemisphere, most likely you will see something related to those important areas: Broca, Wernicke, and the likes. So you are most likely to see them in the question. So once you are seeing them, I told you, just navigate your way towards the left cerebral hemisphere. Once you see Broca is affected, Wernicke is affected. So that's just this area, just for you to remind yourself there is nothing much here. So this lower part here is supplied by the posterior cerebral artery. Just say it like joke. That posterior, I see you here, oh, I see you, you are there. But they won't ask me anything on you. They won't ask me. They won't ask me. Just look at it. This is what they will ask. This is what they will. This one. And that's all. Then we have what we call the herniation syndrome. For those that are used to us, are we here? Are we listening? Are we actually getting it? All right. So that's fine. All right. Let me show you herniation syndrome in step one. I hope I see it on time. So herniation syndrome. 1 minute, please. Okay, yeah. So this is just revise this herniation syndrome that is here in the 1, because in 2 they do not really say much, but you know they will always write notes and the likes. So those people that wrote first aid 2, I don't think they're the one that wrote 1. All right, so that's fine. Now I want you to have an idea of how you'll be looking at herniation syndrome in the exam, because they will just tell you someone had an accident, blah blah blah, and the like, and they will just put 1 or 2 things in the question that will now tell you. They will now be asking, is it the cingulate or subfossa herniation? Is it central transtentorial herniation? Is it onca transtentorial herniation? Just for you to have an idea. You don't need to know it too much. Just get the gist there, and I will try to be precise. All right. There is what you will be looking for in the exam. You will be looking for the pupils, the vital signs. So you will have known that the question is about herniation syndrome. You now be checking. Just once you check the options, you will see that they are say subfossa, cingulate. They are putting all those stuff there. You just know this is herniation syndrome question. Instead of you to start reading like you are a newcaster, just check the question. Any pupillary changes here. That pupillary changes alone. Once you see it, you can pick your answer. All right. Now let me show you. So if the question shows a change in the pupil, if the question shows a change in the pupil, we'll be thinking towards transtentorial. That's that. We'll just be thinking towards transtentorial. But we don't know whether it is central or it is onca. So if the pupils are constricted, they are pinpoints, they are looking pinpoint. So you will be thinking towards central constricted pupil. If they are dilated, you'll be thinking towards onca transtentorial herniation. Both of them are transtentorial. That alone, you just pick your answer and go. All right, so that's just by the way. They hardly ask that which vessel, which I will still advise you to note, but they may ask, where do you think the lesion is? So you just say this patient had a road traffic accident, and they brought the patient had injury basically. They now check the pupil. They now see that the pupils are constricted, they are small in size, or they say they are 2 mm dilated, or 2 mm in size rather. Immediately you see that you are like, this is looking constricted. So with this now, they now say, where do you think the lesion is? The lesion is at the pons. You remember opioid. Opioid, we give pinpoint pupil, opioid intoxication. The same thing for pons lesion, pontine lesion here. If at all there is a herniation that is now affecting the pons, that area, the patient is also going to have small pupils. So please never forget it. Initially it will be reactive, later it won't be reactive again. So the next question is, which vessel do you think is affected? If I ask you now, which vessel do you think is affected? Basically, you are going to be making reference to something related to basilar artery. So you talk about the basilar artery branches, the paramedian basilar artery branches there. So they are affected, so they rupture, and they are the one bleeding. All right, so that's just by the way. Please watch out for this. So if you check it and the pupils are dilated, so if you see the pupil, you go for onca transtentorial herniation. Onca, this is someone that is really not conscious, pupils are dilated, had road traffic accident, blah blah blah, and the like. Just be like, you see that popularity, that you just go for onca transtentorial. That's the answer. So which part of the brain is affected? That's the next question. Midbrain. You can see D, letter D in the midbrain, dilated pupils. Midbrain. You can look at it like that if you wish. Another thing they are most likely going to add to it is about the part of the brain where we are having compression and the likes, or the part of the brain that is dilating, that is herniating. It's actually the onca. That's why you call it onca transtentorial herniation. And another name for onca is medial temporal lobe. This is the medial temporal lobe. All right, now relax. The last thing I'm going to say is this. It's actually about hemiparesis. You will see in them. What they usually have is contralateral hemiparesis. But in that question, it might be the ipsilateral they will give you. So whether it's contralateral or ipsilateral you see in the exam, once you shall see hemiparesis, just know you are dealing with onca. Don't go and be looking for contralateral or ipsilateral. The reason is that if it's ipsilateral, most likely Kenoan phenomenon has occurred. If it's contralateral, Kenoan phenomenon has not occurred. That's why you need to be very careful. Like, I just advise myself not to focus on is it ipsilateral or contralateral. Like, don't really bother that much. So just once you see weakness, you see dilated pupils, you already know where you are dealing with. Just look at it like that and be okay, be happy, move out. Any other little stuff they put there, you can easily do your analysis and go. But don't start complicating matter for yourself, because if you are saying and I will see contralateral and I will now see ipsilateral, so no, you don't need that, because in the exam they may put contralateral hemiparesis. They may, in that question, they may put ipsilateral. Don't bother. The thing does not change the diagnosis. It does not. So please watch out for that. So that's about the pupil. Now, the next one is when we check the question and we do not see pupillary change, but there is weakness. This is someone that had road traffic accident, had this, so there is no pupillary change. Everything is fine with respect to pupils, but there is weakness. So your answer will become cingulate or subfalcine herniation. All right. So you check the question, and the vessel that's affected there is anterior cerebral artery. So please never forget that. Then you check the question, you check it, you are seeing abnormal fighter signs. Abnormal fighter signs. The pulse is abnormal, the BP is abnormal, everything is just the respiratory rate abnormal. Once you start seeing that abnormal fighter signs, be thinking towards cerebellar tonsillar herniation. The reason is this. Look at this number 4 here. It is the one that can compress on this brain stem, medulla, basically. So if it's compressing on the medulla where you have the important centers, so there will be abnormal cardiorespiratory signs. So when you check the question, you see someone had road traffic accident, the patient is a bit unconscious, and the patient, you now check the fighter sign is abnormal. You don't even need to read that question finish. Most likely we are dealing with cerebellar tonsillar herniation, and that's so. Just look at that and go out. So just look at it simply. Even if you solved 1 million questions here, even if I give you 1 million questions here, the question they will give in the exam, it might not even be difficult at all. Like, it might just be one simple question. They will just look at it and be like, this is the answer, and go. So just practice around this, that when I get into the exam, I see pupillary changes, I'll be thinking towards this and this. I do not see pupillary change, I will think towards cingulate or cerebellar tonsillar. So if it's weakness, cingulate. If it's coming with abnormal vital signs and the likes, I'll be thinking more towards cerebellar. The same thing I put there, I put here. So nothing has changed. All right, I put arrow here. So this has been tested before, with respect to cingulate. Now look at the central. So the pupil will constrict. So don't forget this. This is onca. So you'll be talking about dilated pupil. The cranial nerve that will be affected there is actually the cranial nerve 3. Please never forget that. They will ask you this cranial nerve. I left it out there. So cranial nerve 3 is going to be affected. That's actually what is causing the dilated pupil. Then you can see hemiparesis. Just focus on hemiparesis. Whether it's contralateral or ipsilateral they give in the exam, don't be concerned. So now this is a key fact for you, which means it has been tested before. This is a fact you will use in the exam. It has been used before. A blown pupil suggests ipsilateral third nerve compression secondary to onca herniation. I just would forget at your own risk. Like, you can choose to cram all so many things and forget this. So when you see a blown pupil, it suggests ipsilateral, third nerve, compression, secondary to oncar herniation. All right, 1 minute, please. So if you look at it, you don't have much. Don't go and be carried away by the, like I told you last time, you can pick the key facts and just read all of them, revise them, and just enter. Because you may think it's all about how much you learn. It's just simple things they ask. You just look at them simply, and because even if you solve very difficult questions all around the globe, it doesn't guarantee that the question they will give that definitely you are going to get it. But just for you to have an idea and be like, okay, when I see this, I will be thinking towards this. If they say someone had road traffic, I will just look at the pupil. Can you see? Just joke around there. I will just look at the pupil. If it's dilated, I know that maybe I'm dealing with midbrain. Midbrain is affected on car. If it's constricted, maybe I'm actually dealing with pons. If there is no pupillary change, is it only weakness? Maybe I'm dealing with subfoci. If there are abnormal vital signs, in that question, I will just be thinking towards cerebellar. Just look at it simply and leave the rest for those that want to argue. Then look at the circle of Willis and arterial supply. So this circle of Willis, basically 2 points you need to rehearse here very well. Just 2 points. The first point is about this posterior circulation. The second point is about the anterior circulation together with some compression that can happen with the aneurysm you can find there. That's all. Which you can say them by yourself. You can say them and rehearse. All right. So this is how you look at this in the exam. Let's start from the posterior circulation. I used to jokingly say something SAPMA. SAPMA not happen to us, so when people are very broke. So SAPMA, S-A-P, then centrally here, A. All right. So the advantage of this mnemonic here is this. I'm not going to be dissecting this posterior circulation again. We've done it over and over in step 1. So this is not a place where you want to be learning it. You just want to revise it. All right. So this is SAPMA. S here is superior cerebellar artery. A is anterior inferior cerebellar artery. This is posterior inferior cerebellar artery. If you look at all these SAP, they are more or less related to cerebellar. So I don't expect them to put cerebral there and you will be picking it. So why this A here, the last A here, is anterior spinal artery. Now, this is how you'll be looking at it. Let us try to sketch the brainstem here. So this is the brainstem. Can you see? This is the pons. This is the medulla. This is the medulla. Why this will be the midbrain? This will be the mid. This is all you need to rehearse here with respect to this. Now, if at all they give you something related to lateral pontine lesion question, the question will just be which artery is affected here. And how will you know that this is lateral pontine lesion? How will you know this is lateral medullary lesion? How will you know this is medial pontine lesion? How will you know this is medial medullary lesion? Very easy. What you will do is this the place? What you will do is just to, in your head, because you don't have that time again, just to quickly look at what they pack into the question. So this is your step 1. So what you will do, you can look at the cranial nerves that are affected there. You arrange those cranial nerves 4-4. We have 12 cranial nerves. So something related to the brain should be 1 to 4. 1 to 4. Something related to pons will be 5 to 8. Something related to medulla should be 9 to 12. However, cranial nerve 1 and 2, they are not related to the brainstem. So this one will become 3 to 4. All right. So I already have an idea of the cranial nerves I see that are related to the midbrain, to the pons, to the medulla. So you just look at that question, which cranial nerve is affected here? You are seeing something related to oculomotor nerve there. Immediately you see that, just know that most likely I'm actually dealing with what do you call it? I'm dealing with midbrain. You are seeing something related to trochlear nerve. Most likely I'm dealing with midbrain. That's all. It might just be the eyes they will give you, and the eyes will now be deviating one way and different. Just or the patient is having diplopia with respect to one kind of motion. You already know the cranial nerve that is affected. You now be like, which cranial nerve is it? Okay, maybe I'm dealing with cranial nerve 3. Oh, if it's 3, it's related to the midbrain. Then all your answer will be related to midbrain. Your thinking will be related to midbrain. The same thing for pons. You just look at the cranial nerve in that question that is affected. Oh, I'm seeing cranial nerve 6. Oh, I'm seeing cranial nerve 5. Oh, I'm seeing cranial nerve 7. I'm seeing cranial nerve 8. You just look at the 5 to 8. They are related to pons. Okay, this lesion is at the pons. So I'm seeing something related to the tongue. Oh, the tongue is deviated here. Is this, is that. The patient is having problems struggling the shoulder and the legs, uvular deviation, abnormal uvular deviation, and the like. Just be like, this is medulla. So this lesion is at the medulla. Now, the next thing is, all this lesion, I already know where the lesion is, but is it medial or lateral? You don't know. You now look at the cranial nerve that is affected. I'm only reminding you what you know, so I'm not teaching it. You now look at the cranial nerve that is affected. You see, if the cranial nerve that are factors, that their numbers are factors of 12, they are medially located. So if I say we should write the factors of 12, 12 itself is a factor, 6 is a factor, 4 is a factor, 3 is a factor. If any of these cranial nerve is affected, it is medial. So if the question says, okay, it is oculomotor, you look at that question, you're like, it's oculomotor that is affected. Also trochlear is affected. Just know that you are dealing with medial lesion. So your answer will be related to medial part of the midbrain. They have all manner of abnormal name they call them. You don't bother about those highfalutin names. Medial midbrain is medial midbrain. That's the concept they want you to take into the exam. That's all. Medial, midbrain. So if you check the question, you see that this is related to abducens nerve. All right. That is medial pointine lesion. Because the only cranial nerve that's affected in that question is cranial nerve 6. So you just say, this is medial. All right, you check the question, you are seeing cranial nerve 12 is the only thing that is affected here. Then that is medial medullary lesion. That's all. So medial medullary lesion. Do you see? So the cranial nerves alone can give you an idea of what is affected. So beyond the cranial nerves, they are now going to come and give you the tracts that are also affected. So now these are the tracts that are affected. So we have the way those tracts are in themselves. We have the medial tract, we have the lateral tract. The medial tract, you see, they start with letter M. Motor tract, which are corticospinal, corticobulbar, medial lemniscus, so medial longitudinal fasciculus, then the motor nuclei, all those ones, and 3, 4, 6, and 12. So these are just the medial structure. So motor, you already know the patient will have contralateral manifestation. So if the question says the patient is having right weakness, right lower limb weakness, or right weakness, side of the body weakness or something, anyhow they put it, the patient is having weakness, you already know that your thinking will be contralateral. So medial lemniscus, this is all about the dorsal column. The patient is having problem with proprioception, vibration. It's also going to be contralateral because they cross at the level of medulla. Do you get it? So then the medial longitudinal fasciculus. So this patient is going to have internuclear ophthalmoplegia. They won't really be able to perform conjugate eye movement. All right. Then the motor nuclei. So this one is anything that is related to cranial nerves. They are all ipsilateral. So internuclear ophthalmoplegia is related to cranial nerves. So that's ipsilateral. So anything cranial nerve is they are all ipsilateral in manifestation. So this will be ipsilateral. This will also be ipsilateral. All right. So that's just by the way. Why the others here? These ones they are actually contralateral. If you check the question and the tract you are seeing affected, they are related to their spinocerebellar, spinothalamic tract, which is for pain and temperature, spinocerebellar, which will make the patient to have ataxia. Cerebellar lesion, they cause ipsilateral in manifestation. I'm reminding you again in step 1, ipsilateral in manifestation. So that's what you are going to see. All right. So when you check the question, you just see all this stuff playing out. Then sympathetic, you see they will talk about the Horner syndrome. That's lateral 2. Then sensory nucleus of cranial nerve 5. So cranial nerve 5, which is supposed to be at the level of pons, we only really use it. We only really use it to lateralize the lesion. So which means that the lesion may be at the lateral medulla and you will still see cranial nerve 5. The lesion may be at the lateral points. You will still see cranial nerve 5 lesion there or manifestation deficit there. So cranial nerve 5 basically is actually to lateralize the lesion. So that's what we use it for. So just remind yourself this important point. So where does cranial nerve 5 supply? The face. You all remember that trigeminal nerve, and that's that. All right, so that's just what you remind yourself there. Now, come back here. You've read the question. You already know you are dealing with lateral medullary. So the question will now be which artery is supplying it. You just remind yourself that, okay, this will be posterior inferior cerebellar. Can you see? Posterior. Just write your SACPA and just imagine it. So for those that recently did step 1 with us, I told them to sketch something out like this and close their eyes and imagine it. I could have said you should all close your eyes now and imagine it. Like, just imagine the way the artery flow. Do you get me? And just be like, okay, I remember now. So that in the exam, you'll be able to remember again. So if it's lateral medullary, this is the lesion. This is the artery affected. So if it's now the medial medullary, your answer is going to be anterior spinal artery. Can you see? So if you check for the lateral medullary, you don't see pica there, you pick vertebral artery. So 2 of them. Can you see? Supply. This one too. Lateral. Why this is the medial. All right. Come to the pons. The lateral pontine lesion. Which artery is causing the injury? You look at it. This is going to be anterior. SAPA. Anterior inferior cerebellar lesion. Anterior inferior cerebellar lesion. All right. So that's that. What about the medial pontine? So basilar artery. All right. So you see, with respect to the midbrain, you only look at the midbrain arterial supply. Is it upper or lower? For the upper, posterior cerebral. For the lower, superior cerebellar. Can you see? Lower, superior cerebellar. Upper, posterior cerebral. So that's for the midbrain. And that's all with respect to the posterior circulation you need to revise. Neuro is why. That's why you can give yourself a headache. If those tracts will give you, just look at them simply and just practice. That's why it's good to really do this step 1 very well, so that you don't have to overread for step 2. Because the information they test is basically the same. You can use step 1 knowledge, if it's well done, to actually write the step 2. The thing is the same. Don't be deceived. It's basically the same. All right. It's just that the exam in step 1 is focused on all these and which one is this, which protein is causing this. Why the step 2 is more of best next step. All right. So but the description they give in the book, they are basically the same. Now come back to this anterior circulation here. What do you want to take into the exam? Just basically the aneurysm. We've already looked at the homunculus. So the next thing is just the aneurysm. So if the patient is having anterior communicating artery aneurysm, this is your anterior communicating artery. So aneurysm will be compressing on this optic chiasm, and the patient will have bitemporal hemianopia. The second aneurysm is actually with respect to posterior communicating, and is closer to the internal carotid here. So this is where you will see the aneurysm, and it's going to be compressing on third cranial nerve. Can you see? So these are just the two basic aneurysms you don't want to forget here. Just these two basic ones. Don't forget them, and you are happy. You are okay. All right. So that's just by the way here. The other details, you can revise them in one, and that's all with respect to this area. Then you come down to meninges. You don't have much. You don't forget about the notes. You don't have much here. We have the dura mater outside. We have the arachnoid, and we have the pier. You see, the arachnoid and the pier mater, they usually combine to form what you call the leptomeninges. So this will be the leptomeninges. All right. So basically, we have what you can just be talking about the hemorrhages and different kind of thing like that. Basically. So then the what do we call it? The nerve supply that you can actually link to the dura mater, all right, is actually the the fifth cranial nerve, trigeminal nerve. So, and you can also relate this to headache. That's why, with respect to headache, you see it's actually more of trigeminal-vascular mechanism that most of the time leads to headache. All right, so fifth cranial nerve. If you use just this fifth cranial nerve, you can remember. So that's more than enough. Like if I thought they ask me about any this thing, fifth cranial nerve, most of the time. The other nerves, they are the cranial nerve 10, sympathetic, C1 to C3. They hardly make reference to this one, but this fifth cranial nerve, everybody knows that this is what most of the time they are most likely going to test. All right, so that's just by the way. Can you see? Just pick one point and revise this. Things that you can even tell someone subconsciously. What about the arachnoid matter? This here. So arachnoid, this is actually a vascular middle layer. So you have some special projection from it. You call them arachnoid granulation. So what happened is that the arachnoid granulation allows this is the arachnoid matter, and this is subarachnoid space. So the subarachnoid space is where you have your CSF. So can you see? This is now the arachnoid matter. So you now see some projection from it, like this. You call them arachnoid granulation. So this arachnoid granulation, they allow CSF to actually leave the subarachnoid space and be drained into the pharynx sinus, into the sinus. All right. So, if anything happens to this arachnoid granulation, like meningitis, it can be blocked. Like hemorrhage also can block it. So if they are blocked, CSF will be in the subarachnoid space. They can't go into the sinus. So if they can't go into all those sinuses, the next thing, dural venous sinus, they can't go into the dural venous sinus. So if they can't go into the dural venous sinus, the next thing you see is that the patient is going to have communicating hydrocephalus. Can have communicating hydrocephalus. Communicating in the sense that all those ventricles are still communicating with themselves. So it's not that maybe you are talking about blockage between any two ventricles. No, they are communicating. So, but the problem is at this level. So you will be thinking towards this in the exam. If they say the patient had the meningitis, now after that the patient start developing this, or the patient had subarachnoid hemorrhage, after that the patient start developing this, just know that you are most likely dealing with arachnoid granulation blockage. That's all. Okay, so that's for the arachnoid matter. Pier, I told you they usually, this one is in a way adhere to the surface of the brain and the spinal cord. So never forget that. So, and leptomeninges, I've mentioned it. So pia matter and arachnoid matter, the two of them collectively, you call them leptomeninges. And that's all you need to rehearse. Is it the arachnoid granulation you will say you don't know? There is no one here that will say I don't know arachnoid. You just revise it and be like, okay, in case they give me, because the question they will give, I bet it with you. It's not what you might have seen before, unless someone mentioned that this is given to me. All right, so it goes beyond your word, this one, that one, all those. No, they go beyond. That's why you just need to think simply. You can't be having a headache before the head is cut off. No, like the exam is the exam. Don't kill yourself. So just pick one or 2 points and be like, okay, in case the question goes, I will just think like this, whether it's correct or it's wrong. This way I will look at it. Lumbar puncture. So this is for the lumbar puncture. Can you see? So just first of all, for you to have an idea of where the spinal cord actually stop. In the adult, L1, L2. All right. In children, usually goes far downward. It gets to the level of L4 and the like. All right, so just for you to have an idea of where the what do you call it, the tip of the inferior tip of the spinal cord actually stop. So for you to know where you are going to introduce the needle. So the needle for the adults need to now go between L3, L4, L4, L5 if the spinal cord is stopping at L1, L2 vertebrae. So your needle should be around this level. So in the exam, if they now give an adult, you just program your mind that if they say where are they going to pass the needle, your answer will just be something like this. That's all. You might not have seen any question related to this before, but it's a fact you've reminded yourself simply in case they ask me. That's what you go for. All right. Whereas for the children, you go below L4, and that's all. And this is just the way they used to the structures that will be pierced by the needle. So you can look at this structure by yourself. So the skin, fascia, and fat, they label them for us. Then you have these cranial nerves features. You have the third cranial nerve. You just want to have an idea of what is going on with the third cranial nerve, basically. So you just want to have an idea. So this is just what you want to put at the back of your mind. Just this diagram. This is basically what you want to be rehearsing. You can even draw it down by yourself. You don't need to look at, don't cram anything or else you will be over cramming. Just if I thought they asked me a question on third cranial nerve, this is how I will look at it. I will draw a cycle. It might be in the paper they will give you in the exam. I will also draw another small one. This one is medially located. This is M. This one is peripherally located. This is P. So this one that's peripherally located, I'll call it parasympathetic nervous system, PNS. Why this one that's medially located, this is actually for the motor output, Shikina. So centrally, this is for motor output. Peripherally, this is for parasympathetic output. All right, then you now bring the artery. You now put it outside like this. So now this is now your thinking. The nutrient, oxygen, they get to the medial part, central part here, the motor output here, by diffusion. So see where the artery is. You don't have artery within here, you just have artery outside there. So just little trickle to the middle, to the motor. Dr. Salma. Dr. Salma, I don't know why you are raising your hands up. Okay, it's all right. So maybe it's a mistake. Abi, you are not hearing me. Can you hear me? Okay. All right. So this middle part is for motor. This is the peripheral. Don't cram anything here. You will just over cram. So this is the blood supply. look at it critically. So the nutrient that get to the motor we get there by diffusion and all manner of stuffs and the likes. All right. If the parasympathetic is affected, what you will see is that the eyes is going to be the pupils will be dilated. If the motor is affected, what you will see is that there will be abnormality with eye movement. All right. So you now check that question. You now see that you are seeing dilated pupils. Well, that's what you are seeing. Just dilated pupils. You are not really seeing the motor being affected. So your thinking will be like, whatsoever that I'm going to be thinking about here is most likely affecting the peripheral. Then that thing is going to be compression. That's your answer. Are they now going to put compression in the option? Just things that can cause compression, they are the one they will put there. So if they say you are dealing with what do we call it? The patient that recently had road traffic accidents, and you are now seeing pupillary dilation, most likely you are dealing with oncar herniation. Can you see? Because you already have an idea. So if you are seeing pupillary dilation, this patient did not have herniation, did not have road traffic accident and the like. Maybe I'm dealing with posterior communicating artery aneurysm, causing the same compression. So that's how you are going to be looking at it. So you don't need to overlook at it. So you check the question. You are seeing something related to the motor, like cranial nerve 3 palsy. So you are just seeing something that is affecting more of motor in the question. The way the third cranial nerve used to bring down the eyes, down and outward. You are just seeing that in the question. Then that thing is affecting the motor. Whatsoever that's going to affect the motor is most likely going to affect the artery. So let us assume that this artery is narrowed. So it becomes this. Peripheral will still be getting oxygen. However, the central may not really get enough. So the central, where you have the motor output, will now be manifesting more. So your answer will now be something that can affect the artery. Here, diabetes mellitus. That's all. So you need to draw this down by yourself. Look at it. So if I'm seeing more of dilation, pupillary dilation, I'll be going for compression. Just say compression. Simplify it for yourself. Just say compression. You now check the premise on which the question is set and be like, oh, road traffic accident. Oh, this patient is so that's just fine. But it's having hypertension, it's having this, or maybe I'm dealing with posterior communicating artery aneurysm, this one, that one, and the likes. So you check the question, you are seeing motor manifestation more. You'll be thinking more towards something like diabetes mellitus. So there is now another point I want you to note. All right. So when the parasympathetic is affected, usually by compression, when it's affected most of the time, so you still see the motor also coming together with it. So focus on this parasympathetic. This is your main sign here. This dilation, pupillary dilation. So when they put the dilation together with motor manifestation, pupillary dilation together with motor manifestation in the exam, the dilation is what you will use to get your answer. So you just say, okay, the dilation, okay, maybe I'm dealing with compression. That's that. So what I'm trying to say is that you are seeing both of them. Pupil is dilated. You are also seeing abnormal movement of abnormal deviation of the eye. All right. So it is the dilation that will give you the answer. So which means that you will check the option and pick something related to compression. And that's that. Because when there is compression, most of the time you will also see motor manifestation in the patient. But if the question is only showing motor alone, so motor can come alone without pupillary dilation, you will just be seeing ptosis, down and outward gaze, just something related to the third cranial nerve. Then your answer is going to be diabetes mellitus, most likely, just vascular problem. So this is the answer. So in summary, you check the question, you see the eyeball is deviated down and outward, and you are seeing ptosis in that question. So you just say that, okay, this is affecting the medial part of the oculomotor nerve. Then this is what can affect the medial part. Most likely I'm dealing with diabetes, because with diabetes mellitus, it will affect the artery. Enough nutrient will not diffuse to the medial part. The peripheral can still get enough, no matter how. But if you check the question, you are seeing ptosis, you are seeing, down outward ptosis, you are seeing dilated pupil. You will be thinking towards parasympathetic. So more of compression. That's all. So that's just all you are taking into the exam with respect to this. And that's all they have put here. All right. So look at this summary they've given you here. For parasympathetic output, compression, posterior communicating artery aneurysm, uncaenation. You just look at the premise. Is it road traffic accident? Following it, is the patient just sitting down or something like that? So you can easily know which of them is it. These are the two they will put in the option. There will not be any other one they will synthesize elsewhere. It will never happen. If they will set question on this, these are the two. So you just look at it and rehearse it. That's the main thing. And you don't need to cram the whole statement here. Just look at it, draw your own, and look at it that, okay, is it only dilated, or am I seeing dilation and motor together? So if it's parasympathetic, you will see both of them together. So if it's motor, you are most likely to only see something related to the what? If it's vascular, you are most likely going to see something related to the motor alone. All right, so before I start saying rubbish, that's just that. So this is the fourth cranial nerve. So you can look at all you need here is just LR6, SO4, AO, AO3. That's all. So just this is a statement. There is no one here that will say I've never heard about this in my life. It's a lie. So in the exam, you can quickly write this before you start picking wrong answer. Just write it in the book they will put beside you. Then now look at the pupils. Look at the eye, and now quickly do this. Just something within 10 seconds. You just do this. You now do this. You do this. You put nose here. So we'll call this one lateral rectus. We'll call this one lateral rectus. We call this one inferior. So we call this one superior. We call this one medial. We call this one. Now, this is now the caveat there. So we are going to call this one that's going up inferior oblique. We'll call this one superior oblique. So now, if you go and mislabel it in the exam, you are going to miss that question. So what does that one mean? They will just tell you that this patient is now superior oblique here is actually supplied by the trochlear nerve. So this is my trochlear nerve. Why the lateral rectus is supplied by the abducens? This is my abducens. All right. So they will now tell us that this patient, anytime the patient is walking down the stairs, because when you are walking down the stairs, you are looking down, you are looking medially and inferiorly. All right. Anytime the patient is walking down the stairs, or anytime the patient is trying to button the shirt, the patient is having diplopia. It's a diplopia question. Walking down the stair, buttoning the shirt, having diplopia. Once you see that, you are dealing with superior oblique palsy. So which cranial nerve is now affected there? You will go for fourth cranial nerve. And that's all. So that's all. It's a diplopia question. Diplopia. Buttoning the shirt, walking down the stairs, reading, typing on the laptop. So when you see that, and the patient is now having diplopia, you are most likely dealing with superior oblique. And that's that. So we don't have much to remind ourselves there. So that's what they will test. And if I thought you don't see any question on it, just that guy was shouting, that's what they test. That's what they will test. Because it's only like 15 questions or so. Some people might not even get up to 5 neuro question in the exam. So why do you want to kill yourself? That's why no matter how you look at me, I will still tell you. Whether you say the guy does not know us or we don't even know he has a way of talking and the likes, but I will deliver the message. All I know is that I just see myself as a messenger of peace. Whether you know the message I carry or you don't agree with it, I don't care. Because we may not even see. We may not. And if I thought we are going to see, we meet in very, very high places. Just get the message. So you may not even get any question, but you need to be very prayerful. That's even the point I want to make. Just be very prayerful. Because you may get into exam and they will just pack complex questions for you. Someone that is not even half as good as you will just be getting simple questions. The results will now come out. You will see the difference. You now be like, what happened? USMLE is a shit. Is this? It's not like that. Some ride on their strength, others ride on grace. Like, you just need to be prayerful. Yeah, we know you are good. We know you are very good. You believe, just read but you still need to pray. Like, just put it before God. He has a way of, even those things that you think are difficult, you just realize that they do not even ask you any questions on them. Why those few things you know very well, you get into your exam, you are now seeing questions on them? If you agree with me, you don't agree, I don't even care, but that's just the point. So that's for the fourth. The same thing for the sixth cranial nerve. You look at it like that. Now, which message do you want to take into the exam with respect to the fifth cranial nerve? This is the message. Is in step 1, you get the message very well. So this is the message. Most of the time, it's about the muscle of mastication. So then the way the the fifth cranial nerve actually supply mediate the sensation to the face with its branches. Just don't forget that the muscle of mastication, they are all supplied by the third branch of trigeminal nerve. So you don't want to forget this, because they may put first branch, second branch, third branch. You just put them there. Ophthalmic, the maxillary, the mandibular. Don't ever forget it's mandibular. Mandibular. All right, so please never forget that they supply the muscle of mastication. What about the 10th cranial nerve? Everyone here knows the vagus nerve. So it's not a big deal. But what you want to take to the exam is this point I try to underline. So just don't forget the fact that if at all there is a lesion, you will see the uvula will deviate away from the side of the lesion. So if the question says, in that question, just see that uvula deviate to the right, just know that you are most likely the lesion is actually you're having the lesion on the left, uvula deviate to the left, having the lesion on the right. So this is quite important compared to the others. Tongue deviating here, whichever side the tongue is deviating to, so you know that is most likely where you are having the lesion. Do you get me? So if you go and apply the same principle to uvula, you will get the question wrong. That's why you need to note it very well. So I'll just peg all those ones there. I'm done with that. Rehearse that. What about the facial nerve palsy? Facial nerve palsy. The way the facial nerve palsy will manifest is facial weakness. That's the primary information that all of us know. Facial weakness. Now, this is where the question will now come. This is the statement you want to take into the exam. Upper Spears Hopper. You know, this is a statement they used to tell us right from school then. Upper Spears Hopper. Now, the advantage of this is that you want to first of all know, am I dealing with upper motor neuron lesion for this facial nerve, or I'm dealing with lower motor neuron lesion for the facial nerve? So what you will quickly check in that question, you don't have time, just check that wrinkling of the forehead, is it there? If the wrinkling is there, your answer is upper motor neuron lesion. If the wrinkling is not there, you are dealing with lower motor neuron lesion. Just wrinkling. We just say, look at wrinkling. You are looking at everything. Top. Just look at wrinkling. Wrinkling is the main thing you are looking for in the exam. Like, write the statement down when you get to this page. Say it to yourself that, oh, I, Shegun, I am going to look at wrinkling in the exam. It makes your work easier because you are most likely going to remember what you are looking for, because it helps you to know where you are focusing on. To first of all know, am I dealing with upper or I'm dealing with lower? So if the wrinkling is there, you are most likely dealing with what? Upper. If the wrinkling is not there, you are dealing with lower. This might just be the question. Now, why is it important? For the upper, it is contralateral in manifestation. So if you look at that question, the wrinkling is there. Forehead wrinkling is there. You are right. This is upper. They now say that the patient is having maybe loss of nasolabial fold on the right, on the this, on the that. They now say where is the lesion? The lesion is on the left. That is it, contralateral. Manifestation you are going to be seeing on the face is going to be, let me say they say is on the left. And you have already checked the question, you are seeing wrinkling is there. If the wrinkling is there, then you are dealing with upper. With that upper now, it is contralateral in manifestation. So if you are seeing the manifestation on the right, the lesion is on the left. If you are seeing the manifestation on the left, the lesion is on the right. The only statement you need to write down from all these Mahatotono is just upper space upper. And for you to know whether you are dealing with upper, contra, lateral, upper motor, con, not on kong, upper, con, con. Before I start speaking in tongue, but just practice with that so that you remember that it's actually contralateral. You now check the question. You look at the forehead wrinkling. Just quickly trace it. Is there any forehead wrinkling here? The question is about facial paresis. You now see, is there any forehead wrinkling? Forehead wrinkling. Now see, the forehead wrinkling is not there. You call that a lower motor neuron lesion. That's lower motor neuron lesion. Now, that lower motor neuron lesion, most of the time, you peg it on what we call Bell palsy. You just say Bell palsy. Bell palsy. I put something here, ISU, because they love this area. This place, like water, these two. Bell palsy, Bell palsy, Bell palsy, Bell palsy. Just say Bell palsy. Most likely. So if this is Bell palsy, the next thing they are most likely going to test. Just quickly check the question. Can I see anything that is causing it here? Can I see anything that is causing it? So if you can't really see anything that I'm going to bring out very soon, you'll be thinking more towards EPIS simplex reactivation. EPIS simplex reactivation. That's what you are going to go for. Just check it and just they now ask you that what do you call it? Which of the following is the likely cause? So which of the following is the likely cause? Just be like, okay, EPIS simplex. Just look at just pick EPIS simplex. Unless when you check the question, you can see something else actually causing it. And sometimes they may put a clincher that will bring you closer to EPIS simplex. Know that Bell palsy is usually due to EPIS simplex reactivation in the exam. Just see EPIS simplex. So basically, so in the treatment, the patient should actually recover by themselves. However, if I thought they say they ask you which drug do you think the patient will benefit from, prednisone, so it can speed up their recovery. So if you look at it, it's not even something too much. Just say okay, they recover by then. So gradual recovery occurs in most cases. However, prednisone speeds recovery. Then you now come to this lower area here. So now, this area, you will be seeing something related to the facial nerve palsy, usually the lower. They will now add something that is causing it to it. So, which may be HAID, it may be Lyme disease, it may be sarcoidosis, it may be parotid surgery, it may be tumor, it may be diabetes. It will always be there. So it will always be there. Like, you just need to be calm, or else you are going to pick something that does not make sense. So if it's parotid surgery, the question will say that the patient recently had the surgery for salivary gland tumor. Once you see that, and you now check the question, you are now seeing something like lower motor neuron lesion, facial nerve palsy, and the like. Just know that, okay, it's the surgery. What is the cause of the presentation of the patient or the clinical features of the patient whatsoever? Just say, okay, the surgical complication or surgical procedure. So if it's sarcoidosis, definitely you may see something related to the lymph nodes. You may see something related to the skin, all those nodules and the like, or something related to the lungs in the question. So you may see something related to, so you shall see something that shall giving it out. It might even be calcium that you are just going to see that will be very high in that question. Someone is having facial nerve palsy, and you now check, you're now seeing calcium is high in the laboratory. Now say, what do you think is the cause? You just go for sarcoidosis. It may also be a tumor compressing, it may be a diabetes. All right, so just keep your mind straight. It might be HAID. So all you need is that you just want to remind yourself the clincher that will give out the sarcoidosis, parotid surgery, and the likes. The last one is what we call Ramsay-Hunt syndrome. What is this Ramsay-Hunt? So when you are going to see the facial nerve palsy question again, so most likely it's definitely going to be the lower one anyways. So lower motor neuron lesion. You will now see, you will be seeing, what do we call it? Rash, vesicular rash. Is there in the question, and you're seeing facial, and just say this most likely Ramsay-Hunt. Now, with this, the question that will follow is that what do you think is the cause? So varicella zoster virus. So what is the best next step? Best next step, the patient will benefit from either a cyclover or famciclover. So just rehearse it. So what we give this one out is this rash. Just rash. Ramsay-Hunt rash. Ramsay-Hunt rash. He has haunted that patient. That person. He rash out. He rash out to haunt the client. To haunt, rash out to hunt. All right, Ramsay-Hunt, you will definitely see the rash together with that. That's all. Just these statements here, that's all you need. The story will be long. You just see something related to facial nerve palsy, now see the rash, they just say Ramsay-Hunt. So the question they will ask is not about the diagnosis, it's not a syndromic exam. So they will just ask what is causing it. The answer is varicella. What is the best next step? Acyclover or famciclover? So we are done with that. Then you come here. If you look at them, they are all step 1 palaver. You look at this one, it's about upper motor neuron lesion, lower motor neuron lesion. So in upper motor neuron lesion, everything goes up. Everything goes up. In lower motor neuron, everything goes down. Everybody knows that. So when you check the question, I will just bring out 2 or 3 guys that may confuse you in the exam. So just these first 3: atrophy, fasciculation, and reflexes. So I'm not going to be explaining why the reflex is high or is low. So in the exam, you see hyperreflexia, which I will show you very soon. So the reflex is going up, you say upper. You see hyporeflexia, the reflex is going down, lower. Fasciculation. You are most likely to forget fasciculation in the exam. They will mention it. This is the one you are most likely going to forget, that is it upper or lower. Why? You may want to be mistaking it for reflexes. Fasciculation. Once the question says there is fasciculation anywhere, even on the tongue, anywhere they like, let them put the fasciculation. You go for lower motor neuron lesion. You go for lower motor, just say this patient has lower motor neuron lesion. If you now see any other thing that justify upper there, upper is also, you just add them together. You say most likely I'm dealing with a amyotrophic lateral sclerosis. You just see the combination of the two. I will soon get there. So, but don't forget this fasciculation. You see it in lower. So, this one that you are most likely to forget is the one you rehearse. Everything goes up. You can easily find your way around the rest. The tone will go up, Babinski sign. The big toe is pointing up. The spastic weakness or paralysis is there in upper. Flaccid is not there. You see the flaccid in the lower. Fasciculation, you see it in lower. Atrophy. They know you can think, but don't think for them. You check the question, you see atrophy before you start shouting atrophy of disuse. Don't go and say that. You just see atrophy there, just say lower motor neuron lesion. Don't assume that the atrophy is from disuse. They know you can be right, but don't go and make that assumption. So atrophy, once you see it in anywhere, any question, just say lower. So look at these three. Atrophy, lower. Fasciculation, lower. Can you see these two that can confuse you? Reflexes, if it's hyperreflexia, upper. Hyporeflexia, lower. So please never forget these guys at all. These two, just rehearse them very well. The last thing second to the last point I'm going to make for us here is about what we call pronator drift. I'm not going to read these jargons for you. Permit me to show you how the pronator drift will look like. So, pronator drift. You won't forget that one. Pronator drift. You won't forget it because anyhow they describe it, you just say that, this is pronator drift now. So you may not hear the stuff, just look at it.
Turn your palms upside down, hold your arms up. Close your eyes, please, and slowly count from 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Good. And what we do here, we observe to see if one of the arms is drifting, and that would be a positive pronator drift. But in this case, this is normal. Thank you.
All right. So that's actually more of, okay, let's try to look at this one. Because the one that we just watched, the thing did not drift, but towards the end, the instructor was trying to show how the drift is going to be. So I want you to watch this one so that you have an idea. You can also watch
and then you just hold it there as long as you can. Close your eyes now. Close your eyes. And you just hold that there. You hold it there as long as you can. As long as you can. You hold that there. Hold it as long as you can. 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 You just hold it there as long as you can.
Lovely. So if you look at this, can you see this left upper limb? It has drifted. Look at the right one. It's still staying. So this is another way the question can come. Once you see pronator drift that is there, it's not there, is there, it's not there. Because they know all those other ones, you know them. The ones they know you are not really too used to, they are now the one they will pack into the stuff, into the question. Once you see the pronator drift, just know that there is actually upper motor neuron lesion. That's all. Upper motor neuron. Once you see pronator drift, just the upper motor neuron lesion. Anyhow, the question comes. And you will see in 1 is there, in 2 is there. So these are now look at this question. I'm not really for you to just see the question. A 36-year-old woman is evaluated in the clinic due to left-hand clumsiness. The patient works as an office secretary and has been having difficulty typing. That's my story. 6 months ago, she had an episode of vertigo, difficulty walking that improved after several weeks. The patient also has a history of bipolar disorder and takes valproic acid. On physical examination, she is asked to close her eyes and stretch out her arms with the palm facing up several seconds later. Her left arm involuntarily drifts. Can you see? Involuntarily drifts downward and the palm turns towards the floor. If you look at the first video, second video, they justify this. Which of the following best explain this? So the best is lining just upper motor neuron lesion, and that's all. All right, so please watch out in case that's actually given in the exam, so you have an idea and be like, okay, this, in case they now say is it left or right, it's just going to be contralateral. All right, definitely. So that's for this. This is what they can put there down. The last thing here is about anytime you read the question, you now see upper motor neuron lesion, upper motor neuron lesion. You can see the manifestation. You now see what's the best next step. The best next step is going to be MRI, because you want to know what is causing the upper motor neuron lesion. If it's upper, you are dealing with corticospinal tract. It may even be at the level of the cortex. It can be anywhere. Upper is upper. Do you get it? So when they say what's the best next step, best next step, best next step, just check the option and pick the MRI. So what is difficult here? The only thing I might think you might not really have noted before is pronator drift, which is what most of the time we characterize the question. They never forget the fasciculation for the lower motor neuron lesion. Reflexes. We know you like to cram a lot, but don't overthink it. I think someone wanted to ask something. So don't overthink it, basically. Just remember the number 2. This number 2. That's all I want you to remember with respect to the grading of the reflex. Now, why is this one important? In the exam, they may say the reflex is +1, the reflex is +3, the reflex is +4. Before you start shouting, is it hyperactive? Is it clonus? Is it... No. You don't have that time. 2 is 2. Any number lower than 2, hyporeflexia. Any number higher than 2, hyperreflexia. That's all. Just remember 2. That's why I just wrote it out very big. Is it hypo or hyper? You can look at that question just within 1 second and say hyporeflexia. So if it's hyporeflexia, you are most likely dealing with lower motor neuron lesion. If it's hyperreflexia, you are most likely dealing with upper motor neuron lesion. Reflexes has gone up. All right. The next thing is another word in case they don't give you number. The second word that they can use patapata is brisk. Brisk. Before you get into exam and you start saying brisk, this is sounding like it's reduced. That's wrong. Brisk reflex is hyperreflexia. That's another name for it. Because you understanding this word brisk will determine whether you are going to get the question right or wrong. Because both upper and lower motor neuron lesion will be in the exam, in the option. So you just revise this. Brisk, when you get into the exam, you see the word brisk, you just say hyperreflexia, 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 and that's all. So now, these are the common reflexes that they can talk about. And just as usually, they peg this one on step 1, but you can revise them. So Achilles. I used to say Achilles. 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 This is my own Achilles. S1. Patella. 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 So this is looking more like L4. If you want to write your 4, this is how we write 4. Some people will write their 4 like letter A. So 4. L4. You can use that if you wish. So that's for patella. This is for Achilles. Tricep. Okay, bicep. So if I say, write down the spelling of bicep, I just say bicep. So B-I-C-E-P. BICEP. Some people will write BICEP, some will put S, some will not put S. All right, so if you count total number of letters here, 5. Those that put S there, that will be C5, C6. And that's where I try, and that's okay, first of all, is it spelling correct? And that's okay, the spelling should have letter S in it anyways. So you now come to triceps, and that's where I try triceps. So everyone will now write TRICEPS. They say, okay, we won't forget to put S now. You count the total number of letters there. That will be 7 letters, C7. So you just have an idea and be like, okay, I think in case they ask you, bicep, tricep, bicep, just speak it. The same thing for brachioradial reflex. For those that did musculoskeletal step 1 with us, we will have seen a diagram that we brought out to show you this. All right, so that's that. What about the cremasteric reflex? So cream your, I just say cream your first and second leg, L1, L2. Some people used to have anal sex. So when people want to write sex, sometimes they write it like this, S3, X like this. Some people write sex like S. They will now put star here and now put X here. I don't know what they are trying to say, but sex is sex anyways. All right, so 4. You can look at fork. 4, fork. You can look at it like that. Sorry to use that, but that's just for you to have an idea of how to look at it in the exam. All right, so Anna wing. So Anna, you can look at it as Anna sex, S3, S4. So S fork. You can look at it like if you wish. If it doesn't make sense to you, you can throw it away. But I know some people will get the exam and remember that. And you are done with that. So when you come here, instead of you trying to cram everything, just look at number 2, look at brisk. You just say, don't forget brisk in the exam in case they bring. Because it's not that maybe you don't know upper motor neuron lesion or lower motor neuron lesion. It's not that maybe you don't know those guys. You know them. You can even analyze the question better. But when you now start seeing them giving you bigger number, using the word brisk, mentioning pronator drift, you now start saying the question is difficult. No, yeah, just these are the things they will put in all those questions. They can't go beyond this at all. It doesn't go beyond this. Now, these are the spinal tract function. Spinal tract function. So if I say we should mention the tract now, we are going to say we have what do we call? We have the corticospinal, dorsal column, spinothalamic. At least the major basic ones. Spinothalamic, you can see spino, P and T. T is from the thalamic, P is from spine. So pain and temperature, mediation here. All right. While the corticospinal, is for motor. Dorsal column, is for all these proprioception, vibration, 2-point discrimination, fine touch, and the like. That's for dorsal column anyway. I just say PVT, proprioception, vibration, and touch, fine touch. All right. How will I now know the one that crosses at the level of the medulla? The one that does not cross at the level of the medulla. So what I will do is this. I will call this medulla. I will now call this one spinal cord. First of all, what did you draw? Funnel. I just drew a funnel. All right. So I will now say that. Let me say I find myself in the exam. I'm like, which one cross at the level of the medulla? Which one cross at the level of spinal cord? So which one is that? The ones that cross at the level of the medulla, you see the word dorsal column, corticospinal tract, cross. So dorsal column will cross at the level of the medulla. Corticospinal tract will also cross. So corticospinal tract is a descending tract, so it's going to come here and cross. So it's coming like this. I will just come here and just say cross. Then it's going to come down. So dorsal column is going to be like this. It's going to rise like this. at the dorsal column, and the next thing you see is it cross. Can you see at the level of the medulla again? All right. So please never forget that. So that's how they cross. All right. Just for you to, I'm only showing you a line. You know, we have different neurons. So then the spinothalamic tract, this bastard crosses at the level of the spinal cord straight. So this one will just come. Sorry. So this one will just come and cross like this. Then it's going to ascend. Okay, now we've drawn this. We just drew a funnel, and we just try to illustrate some lines there. The question now say that there is a spinal cord lesion. So I will now come here and just say, okay, you are giving me a spinal cord lesion here. So if this is the lesion here, this is where the lesion is. So the manifestation I'm going to see here is going to be contralateral loss of pain and temperature. So I'm going to be seeing ipsilateral. Can you see? Ipsilateral, because the side of the lesion is actually where I'm going to be seeing impaired, reduced motor function. Corticospinal tract that's affected. Can you see it? So something like this. So if I'm also, I'm making reference to the dorsal column tract too, I'm also going to be having ipsilateral. If I draw the one of dorsal column on this side too. So let me assume that I just draw something like this. So this is what you are going to see. Then I now say like this, crosses like this. So if the thing is picking it too, you will be seeing ipsilateral. So if you look at the ones that you just need to draw it, I don't have any other way to before I start complicating the matter again. Just draw the funnel. Remember, just say, okay, corticospinal is coming from the cortex going to the spinal cord, is a descending tract. Dorsal column is actually ascending. So two of them, they cross at the level of the medulla. Spinothalamic crosses at the level of the spinal cord. So roughly immediately. So it's entering, it's just going to cross. So you now see the patient is having hemisection of the spinal cord. So this is the hemisection now here. So this is the hemisection here. So this is the hemisection here. The next thing is, okay, spinothalamic is going to, since that one has crossed, so this one is going to be contralateral, while the rest, they are going to be ipsilateral. Whereas if they say the patient is having brainstem lesion, let me say the medullary lesion and the likes. So here now, if I thought there is a medullary lesion here, the manifestation is going to be contralateral. Can you see? For the motor and also for the dorsal column. Do you get it? So that's why when you are looking at the brainstem, you can look at it and just put the lesion anywhere and do your analysis. I don't think we need to over explain this before you get it. So that's just by the way. In the next 10 minutes, I will allow us to go for break. What about the polio? These are just some, spinal cord lesions they can give in the exam. You don't need to go and cram. You just need to have a simple way of, you don't try to score all the question, because if you are like, because you want to answer 10 questions or 5 questions that they are going to give, you just be having unnecessary headache. Just pick 1 point or 2 points, and those people that pick 1 point or 2 points, I noticed that they actually do better than people that will just want to get all the points flying around. They end up missing them up. Polio. What will I see in the question that will tell me this is most likely polio? There will definitely be a fascination history. So let us call it fascination history not giving question. No, fascination history unknown question. And the patient is now coming down with weakness. Just say most likely I'm dealing with polio. Just pick polio and say, if I thought you have any other thing in mind though, I don't care. I'm not a neurologist, but I think this is most likely to be polio. And just go. Polio. All the other unnecessary jargons will be in the question. They will put them there. The patient is having this, is having that. They now go to a particular portion of it and now say that the fascination is not known. It's most likely you are dealing with polio. You are seeing weakness, and that weakness is going to be asymmetric. So this is asymmetry for polio, asymmetrical manifestation. All right. So if I thought they say what are you going to see? What's the best next step? So what you are going to do is actually more of lumbar puncture. And you see lumbar puncture. And when the lumbar puncture is done, what you will see that, which they are most likely going to give, you call it pleocytosis. So pleocytosis. What's pleocytosis? Just see increase in cell counts there. Leukocyte count, pleocytosis. That's that. All right. So you've seen that. You look at the question and are shouting polio, polio, polio. If God will have his way, you just say what's the diagnosis. So just say polio, poliomyelitis. So they now say best next step lumbar puncture. They say what's the most appropriate next step in this patient. That's more of treatment. It's just supportive treatment. That's all they say you should just bring. Supportive, 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 support. I just put something here, look for fascination history. Now tell us what is difficult here. Now, another question I want to predict is more or less that they already know that you know that this is polio. They must be like, what do you think is causing it? It's actually caused by the polio virus. So which belongs to the group of enterovirus, to this picona virus. I don't know whether you call it picona virus or pico-RNA virus. Maybe that's what you call it. Picona virus or pico-RNA virus. If that's fine, shall remember pico. Any of them they can use. So if I were you, I would just re-ask picona, that in case it's picona or pico-RNA they are using this, or they are using entero, or they are using polio virus. Any of them that they are shall using, I shall know that I know it. How is it transmitted? Fecal-oral. That's all the other jargons, you can ignore them. Just close your eyes, look at it and be like, I read the question of someone, maybe a child, that is not, the fascination history is not known, that is now coming with lower limb weakness, lower limb or lower extremity weakness, and that is actually asymmetrical in manifestation. You just say, what do you think is going on? I'll just say poliomyelitis. You just program your mind like polio. You just say polio, 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 polio. Even if someone is trying to tell you, I think that question is looking more like, just say it's polio I pick, because there is no fascination. They don't know the fascination of that patient. Let them be arguing with themselves. Make it easy. Because they will always set question. But those clinchers will just be there. If you like, go and overanalyze it and say that, yeah, I feel, because you will just be surprised that that thing you think is actually the diagnosis is not the one. With your overanalysis, I see. They say, they even give me the toe. They say the toe is doing this. They say the other toes thing, they are doing like this. They say the patient, I think this patient is having, and you see fascination history there. Most likely is polio. Pick folios there. Leave them to be arguing with themselves and work out. And that's that. What about the spinal muscular atrophy? Spinal muscular atrophy is most likely going to present just more or less like this polio, but this one is symmetrical. Symmetrical. All right, so this is symmetrical. All right, if this is symmetrical, you remember in biochemistry, we might have done, for those that did biochemistry with us, we might have done something about the spliceosome, the way it's formed, how the survival motor neuron is actually important in the formation of those SNP and all manner of stuffs. So, just know that in spinal muscular atrophy, there is a mutation in survival motor neuron gene 1 and 2. So the patient is now going to present with all this muscle wasting in the limbs. So some respiratory manifestation, brainstem and the likes. But there we always going to be a clincher towards all these SMS, spliceosome, something related to that. How will you diagnose it? This is now the question. You now say that, okay, what's the best next step? You look at the picture. This is someone that is born, that is having this weakness, that is having this, that, and all manner of stuff. They say that, okay, with further analysis, they realize that there is a problem. So what do you want to use to actually make your definitive diagnosis? So just genetic testing. That's just where I'm going. Genetic testing. Okay. How, Festus, I've not still really gotten this. How will I know it's not polio? They will give you the CSF. In the polio, you will see pleocytosis. in the CSF for this, because this has nothing to do with all those infection, is going to be the normal CSF finding. So this one, pleo, play with polio. Just play with it and say that pleocytosis is not important. It is very important to this pleocytosis. Lumbar puncture will show pleocytosis for polio. You won't see it here, in case they are looking alike. Before you start shouting, it is this, it's not the one, it's not the one, it's this one. So don't forget fascination, don't forget pleocytosis I've mentioned. Treatment, supportive too. So don't go and be looking for a drug. Multiple sclerosis. We are not going to be doing multiple sclerosis here. So we'll be looking at it later in the study. Okay, because I'm going to talk about the transverse myelitis, so I'll just remind you maybe when we come back from break. So let us go for our break. When we come back from break, we'll start from multiple sclerosis and start to go down in the study. So we have 23 minutes break. Enjoy your break. Thank you. So this is multiple sclerosis. Sincerely speaking, if they throw 20 questions out of multiple sclerosis as we are sitting now, I'm very sure you are most likely going to get the 20. That is, step 2 does not mean the questions are difficult. Just that they may add one or two other stuff to it. Alright, that possibly you may not be paying attention to before. So, but it is basically the same. So this is what we have. You know that it's actually more of autoimmune in a way. So it can also be caused by Epstein-Barr virus. Just for you to be like, in case they ask me about infection for it, and just yes, Epstein-Barr virus. Then there is one particular vitamin that they are most likely going to test in the exam with respect to it. That's vitamin D. They are not 2, they are not 3. D is D. Just a vitamin D. So, and you can easily predict why they are also going to have the vitamin D. So, because of the kind of environment where most people that usually have the condition, where you find them. All right. Then another important point that you want to note is what characterizes it. So, the first on the list is that you have so many tracts. Any tract can be affected, in as much the tract is found in the central nervous system. So if I now say tract is tract. You don't really need to sit down and be listing tract. No one is going to ask you to list tract, and they can give any tract. Any tract is tract. Tract is tract. In as much the tract is in the central nervous system, definitely it can be affected. So you can look at it like that. So what will happen to those tracts? Demyelination. You remember? Demyelination, multiple sclerosis. All right. So apart from those tracts, there is a particular nerve that is regarded as part of the central nervous system. In fact, we look at it as an extension of the central nervous system, and that is optic nerve. So you will see optic neuritis or optic nerve involvement in that question. So that, first of all, we draw you closer to it again and be like, okay, so there is involvement of the optic nerve here. And this optic nerve involvement will differentiate whatsoever you are seeing here from transverse myelitis. Because transverse myelitis, if this is the spinal cord, you can have all manner of tracts also being affected here at the level of the spinal cord. But this does not get to the what? To the optic nerve. So you are not going to see optic neuritis in transverse myelitis. So you are most likely going to see optic neuritis in multiple sclerosis. All right. The next thing is actually about the diagnosis, which we'll be looking at later. So the treatment, we have all manner of treatment, which we are going to look at later. The way they will come and what we make you to go for which one. So basically, and the most tested concept this treatment is just this treatment for the acute manifestation, and that's the intravenous steroid. So you can even predict that it's most likely going to be intravenous steroid that they are going to test. So, which you know already from step 1. You just paint this and just say, what do you think the patient will have? Yeah, in question bank, you see them testing all manner of drug. They are most likely going to test this IV steroid, methylprednisolone. So that's what they are most likely going to test. So, but when we get there, we'll look at the other drugs, how you look at them in a very simple way. You can now go and be complicating it if they are too simple. So, we'll look at it again. Transverse myelitis. I think this is the only place where transverse myelitis is mentioned. So, what are we going to see here? You also see a lot of tracts actually being affected. In fact, some people look at it as being part of multiple sclerosis. So when you look at that question, you may be confused that, am I dealing with multiple sclerosis? Am I dealing with transverse myelitis? If you can quickly check for optic neuritis there, please just quickly check for it. Are there any organisms that can be involved here? Yeah, Treponema pallidum, Mycoplasma, HIV, entero. The one for the multiple sclerosis, Epstein-Barr. All right. So, what will the patient present with? Just something similar to multiple sclerosis. However, this one is just involving the spinal cord. It has nothing. It doesn't get to the upper part. All those ventricular area, periventricular, it doesn't get there. All right. So, how are you going to? What will you see there in the question again? You can see something related to upper motor neuron. You can also see something related to lower motor neuron sign there. Do you get me? And when you do the MRI, when you see upper motor neuron, lower motor neuron, you may be thinking towards all manner of stuff like amyotrophic lateral sclerosis. But there are some clinchers that will also help you out. One of them is this pleocytosis with a lumbar puncture, just as you see it in polio. So please never forget this guy. Then the treatment is roughly the same with multiple sclerosis. So if you are not very careful, you may not even know that it's actually transverse myelitis. So multiple, I called it multiple sclerosis at the spinal cord level. That's transverse myelitis. No optic neuritis in the patient. All right, you can look at it like that. We are just going to peg that on there. Brown sequoia is not what you don't know, just a hemisection of the spinal cord. So, and this is amyotrophic lateral sclerosis, ALS. All you are going to do, you will see in question for this ALS that will give it out, is just upper and motor neuron lesion. Upper motor neuron and lower motor neuron lesion sign. That's all you are going to see it. The rest, don't give it. Let me try to show you, give you an idea so that you have an idea of how it may come. So, look at this question. 56-year-old woman is evaluated for month-long history of intermittent weakness of the right foot and a 3-month history of progressive left arm weakness. Weakness is weakness, which you can see in both upper and lower. All right, just notice this patient is having weakness. The patient has no dysphagia, dysarthria, sensory loss, bowel or bladder impairment. Other medical conditions include type 2 DM, hypercholesterolemia. Just story. She takes metformin, atorvastatin, lisinopril. You just be like, what's going on? Temperature is 36.9, blood pressure is 130/78, pulse is 80, respiration 14. You are still like, I don't know what's going on. Neurology examination review normal speech, language, mental status, moderate weakness, and atrophy. Now you now see atrophy of the distal muscle in the right leg. So you know that when you see atrophy, in which one do you see atrophy? Lower or upper? Atrophy. Lower. So just by seeing this atrophy, I'll just say lower motor neuron lesion is here. The next thing is fasciculations are present in the right leg. Where do you see fasciculation? Lower. So you can see lower. Now say deep tendon reflexes are brisk. So what is brisk?
Hyperreflexia.
So in which kind of motor neuron will you see hyperreflexia?
Upper motor neuron.
Immediately you see that, just already know the diagnosis. You are seeing the combination, just be like, most likely I'm dealing with both what do you call lower motor neuron lesion, upper motor neuron, likely I'm dealing with amyotrophic lateral sclerosis. And that's all. That's how all the questions will come. You don't need to give yourself unnecessary headache. That's how the questions will come. So if they are, the next thing they are asking here is that which of the following will be most helpful in treating this patient current condition, and that is really so, which you know right from step one. All right, so just remember, combine upper motor neuron and lower motor neuron deficit with no sensory or oculomotor deficit. So you not see any sensory, you not see oculomotor deficit there. All right, so it's actually more of just motor neuron lesion. That's all. So because you may be like, how will I differentiate this from brown sequence? Brown sequence, you will see some sensory deficit. How will you differentiate this from transverse myelitis? In transverse myelitis, you can see subsensory deficit because this is, as when that tract passes through this spinal cord, it can be affected. So, however, for amyotrophic lateral sclerosis, this is all about the motor neuron, lower and upper. That's all, and that's the only thing you will see there. You will not see sensory deficit, although you won't see them there. So now they ask you, the treatment, Relusor. So never forget it, Relusor, and that's the drug. And this is the next one: complete occlusion of anterior spinal artery. Complete occlusion of the anterior spinal artery. All you are going to see here, another name they call this is anterior cord syndrome. It's just anterior cord, everything anterior. Yeah, that's what you will see. You're like, this is becoming complex. How will I know? I will show you how you will know that the question is anterior cord syndrome or complete occlusion of anterior spinal. It's just about this anterior spinal artery. All right. The way the question is going to be coined is actually about someone that recently had abdominal aortic surgery. That's how the question is most likely going to come. So you will see all manner of story. I will try to show you one so that you have an idea. They will now say the patient had abdominal aortic surgery recently or something. So during that time that the patient was having the surgery, there is a particular artery that was damaged, that is most likely to have been damaged, and that artery is actually an artery of Adam Kiewicz. Artery of Adam Kiewicz. So just rehearse it, say it to yourself. Just say maybe they were doing abdominal aortic surgery, and during that time, artery of Adam Kiewicz is actually damaged. So at the level of T10, T12, which I just want to give you a note here, but you don't really need it. At the level of T10, T12 area, the major vessel that feed into the anterior spinal artery here is actually Adam Kiewicz artery. It's Adam Kiewicz. So, which is actually a branch of posterior intercostal artery, which is a branch of abdominal aorta. So, if anything happens to the abdominal aorta, posterior intercostal artery will not get enough blood. So, Adam Kiewicz also will not get enough blood. Enough blood will not come to anterior spinal artery. So, you will now see this anterior cord syndrome being manifested. That's all. So, the story will not be what we give it out. It will just be overreading the story. This thing I highlighted here is what we give it out. Now, let me give you an instance. All right. Look at this question. I have quite a number of questions. All of them, they look alike. So, see this. A 69-year-old man is evaluated shortly after undergoing elective surgical repair of descending thoracic artery aneurysm. Immediately you see that, there is a descending, they had a procedure on thoracic artery. If anything happens to the thoracic artery, thoracic aortic aneurysm. If anything happens to the thoracic aorta, abdominal aorta also will be affected. And I say he has weakness in both lower limb, lower extremity urinary retention, which were not present before the procedure. You don't need to read this kind of question finish. This premise is most likely going to be there in all the questions. Is most likely going to be there in all the questions. This does not follow trauma. It's not a traumatic question. So most of the time it follows this premise, which is what you are expecting them to give in the exam. So you just program your mind that for this anterior cord syndrome in the exam, if they give me like this, I'll just go for it. So you just look at it, say which of the following is most likely the cause of this neurologic dysfunction. You just quickly go to spinal cord infarction. Spinal cord infarction. Anterior spinal artery is affected. Do you get it? So something like that. So that's how most of the questions will go. You can look at this, you can look at this, and the like. So the same concept. Look at this one too. 35-year-old man is brought to the emergency department after crashing his motorcycle into guardrail at high speed. Now say he was riding without helmet and bravely lost consciousness, but he is now awake and alert in the emergency department. Now say blood pressure is 127, pulse is 96. The patient is wearing a cervical collar and his breath smell of alcohol. Now say bilateral pupils are equal and reactive. There is chest wall bruising and tenderness. Now say heart, breast sounds are normal. The abdomen is soft and not tender. There is no obvious deformity. Now, the examination shows bilateral lower extremity weakness, light touch, vibratory sense is present. In both legs, but there is loss of pain and temperature sensation. Now tell you that the bilateral upper extremity motor and sensation is normal. Injury at which of the following sites is most likely? The cause of this patient neurologic distinct. I think this is actually quite easier than you think, because in this question, the only thing that is spared in this question, in the patient injury there, that neck injury, so is this dorsal column. That's the only thing that is spared. This dorsal column is the only thing intact. The others, they are affected. So immediately you see something like this too, you'll be thinking towards anterior spinal cord. So likely that C-spine injury that the patient had is actually affected the anterior spinal artery. So you can look at it like that. All right, so that's just by the way, from that kind of, which is not common. So most of the time what you see is just this abdominal aortic surgery. So when you see this in the exam, they ask you what's the best next step and the likes. So just know, they say someone is having neurologic manifestation following aortic surgery, blah 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 and the like. Just say you want to go and do MRI of the spine, of the spinal cord. So that MRI will now show you the lesion in the spinal cord. You'll be able to see it. Please never forget MRI. All right, syringomyelia. There's no one here that will say, I don't know how syringomyelia will come. Cape-like manifestation. So this person or patient can burn the hand. What is cape-like? So what is cape-like? Let me show you the picture here, so that you say you know. So this is cape-like. So this is cape-like. See this upper part of the chest, the upper limb. Can you see this cape-like? So this person can be burning the upper limb while cooking and the person will not know. So once you see that in the question, you are most likely dealing with syringomyelia, and that's that. Just something light and nothing too stuffy. All right, so what is that carry that is most likely to be associated with? So it may be associated with carry what? Carry 1. What about the central cord syndrome? Usually follow trauma. Usually it follows trauma. And if you relate it to the anterior cord syndrome, they don't look alike. In anterior cord syndrome, dorsal column is not affected. In this one, dorsal column is affected. So it's just central. So please watch out and the like. So how will you now know that this is central? Program your mind. They give you a question. They say the patient is having weakness in both upper and lower extremity, and it's more pronounced in the upper extremity compared to the lower extremity. Just know you are most likely dealing with central cord syndrome. You are like, how will I know? First, how did you arrive at that? This is it. So this is actually how you represent the whole body in the brain. So this is the head. I usually say that on the head, we usually grow gray hair. We grow gray hair. That's what we see on the head. So head will come towards the gray matter in the spinal cord, while the other part of the body will fan out. Some people that are used to us will have heard me say this couple of times. Head here too. This one also will fan out. You can look at it like this. Head there too is also going to fan out. The other part of the body will fan out. So if you look at it, their head is coming towards, or like the upper part of the body is coming towards the gray, the central area. So which means that this patient is most likely, a patient with central cord syndrome is most likely to have more manifestation around the upper part of the body than the lower part of the body. And that's all. And that's all. All right. So please never forget that. And what can cause it? hyperextension injury in individual greater than 50. So hyperextension, you can imagine the car is moving and there is a way the injury shall occur. You can try to check it. So just see that hyperextension of the neck. So it can actually cause what do we call it? Central cord syndrome. So I know some of us that might have seen it. Just remember weakness. Just say weakness more around the upper part compared to the lower part of the body. I will just be like, I hope I'm not dealing with central cord. Just a central cord syndrome. Tapes dorsalis. I put an arrow here because it has been tested before. So tapes dorsalis usually caused by tertiary syphilis. Everybody here knows that. So it can affect the nerve root. It can also affect the dorsal column. So that's for tapes dorsalis. So you may see some joint abnormality. Bony abnormality. You call it Charcot joint. So you can also see, they may say the patient is having syphilis. They may put VDRL, treponema test, and the likes. They may put all of them there. So just know that, okay, this is most likely I'm dealing with tapes. So tapes dorsalis is basically located around the dorsal column. So that's why you are seeing dorsalis coming out of the name. Tape dorsalis is just dorsal column area and this nerve root. All right. What about the vitamin B12 deficiency? There will be a premise that will tell you that this is vitamin B12 deficiency. We usually call it, say that it causes subacute combined degeneration of the spinal cord. Just remember dorsal column, and also you now see something related to corticospinal tract and some other tract like spinocerebellar. So just this diagram alone gives it out. So you can see dorsal column is affected here, dorsal column is affected here. So why this one is having lateral corticospinal involvement, so it will help you. Then the premise they are going to lay down is most likely going to justify vitamin B12 deficiency. So you don't need to cram everything. So if dorsal column is affected, you will see impairment in proprioception, vibration, fine touch. This one too, impairment in proprioception, vibration, fine touch. Can you see? So this is completely different from central cord syndrome, because whatsoever you talk about here is more pronounced in the upper extremity compared to the lower. You don't have such here. So if the patient is having impairment in proprioception, vibration, and fine touch, then you see it in the whole body. So the same thing for this area too. So you can't mix them up. The one that is having lateral corticospinal tract involvement, vitamin B12 deficiency. Let me just show you, just for you to have an idea. I think this is more of diagram. Let me show you the diagram so that B12 deficiency. See what they are giving here. What do we call this? What do we call this? What I'm putting my cursor on here.
Hypersegmented neutrophil.
So anytime you see hypersegmented neutrophil, what comes to your mind? Mega what?
Vitamin B12 deficiency.
Megaloblastic anemia.
Megaloblastic anemia. So that's what's comes. So what are the causes? You just be like maybe vitamin B12, folic acid, and all manner of stuff like that. So they now tell you the patient is having some neurologic manifestation. Just be like, likely I'm dealing with vitamin B12. Because you have neurologic manifestation in vitamin B12, you don't have that in folic acid deficiency. So please never forget that. Can you see something light and easy? It's what you know. So don't be carried away by the way the thing is written and say that maybe what they are going to ask will be difficult. So what about the cauda equina and conus medullary? You just need to differentiate them. And I have one simple thing that I will just tell you. So let me show you the cauda equina for those that are used to ROS. They will know that this guy has talked about this before several times. So this is actually conus medullary. Then you now have nerves coming out around this area. So you can look at it like that. So if at all we are having lesion here, if at all we are having lesion here, so in the conus medullary, so this, you can interpret this as upper motor neuron lesion. So we can also have lesion here or here on these nerves that are coming out. You can look at this as lower motor neuron lesion. So the same thing you've noted about the upper and the lower, you just look at the question and be like, with whatsoever SADU, anesthesia, loss of bladder, and anal sphincter question, am I seeing hyperreflexia? Am I seeing hyporeflexia? If you check the question and you are seeing hyperreflexia, you go for conus medullary syndrome. If you check the question and you are seeing hyporeflexia, you go for cauda equina syndrome. That's all. This is the cauda equina, the tail. That's something that looks like the tail of the horse. Cauda equina, cauda equina. This is the conus medullary, like a cone. You know, the ice cream cone. So something like that's how this thing is looking. And that's it. All right. Again, if there is a lesion in the conus medullary itself, that is upper motor neuron lesion. So when you check that question, you will see something related to hyperreflexia, which may just be related to the anus. They just when they check when they check the anus, they are seeing something that look like hyperreflexia. Anyhow they put it, just be like, this is looking more like conus medullary, because in that one you will see elevated or increased reflex. However, if they say the reflex, they just describe the reflex around that question, and they now say it's low, you'll be going for something like cauda equina. That's the lower part here. Do you get it? And that's that. The question is definitely going to be something like SADU, anesthesia, loss of bladder, and anal sphincter control, blah, blah, blah question. It's the same thing. So you now check the reflex there. Is it high? Is it low? If it's high, you go for conus medullary. If it's low, you go for cauda equina. So don't go and be cramming what is not lost. So very light, something very simple. All right. This is the diagram I drew for us the other time. Can you see? This is the diagram. Head will come towards the gray matter, and the rest we find out. Head will come towards the gray matter, the rest we find. You can look at it like that. So in central cord syndrome, you know that definitely you will see more manifestation around the upper part of the body compared to the lower part of the body. Very easy, straightforward. So you can see here too. So very easy and straightforward. And that's all about that. Let us quickly look at the headache. If you can, I just need to show you the way you'll be looking at. I know you know it, but just for you to have an idea in the exam in case they are playing around drugs. So when you are rehearsing towards the exam, for those that will be writing their examination very soon, beyond you just diagnosing headache, because the question is not likely about you diagnosing headache. It's not about is it cluster, is it migraine, is it tension. It's not likely going to be that. It's most likely going to be about the treatment. That's all. It's just most likely going to be about the treatment. So if I say all of us should talk about the migraine headache now, I'm very sure the experts and mentors here, they are going to formulate a lot of great things out. Be like, this what's going on, this how it occurs, this, that, and the like. So it's not something that we don't know. But to still remind us a bit, so this is, you are going to see something related to aura in the question. So when you see this patient is having a headache, and before the headache is going to start, the patient is having this, maybe auditory, visual, aura, or something like that. So like scintillating scotoma or something, anything for the visual aura. So you shall see something related to aura in the question. And the question says the headache is actually, what do you call it? It may be pulsating. It's pulsating. So you are seeing something related to that is unilateral. So it's actually associated with nausea, vomiting, and the likes. Once you start seeing something like that, you know that you are most likely dealing with migraine. You can also see photophobia, phonophobia, all those guys that you know they can be there. It's just a migraine headache. So that's just for you to diagnose it. You are not expecting much there, just for you to diagnose. Now, this is now the first question you want to note for the exam. The first question is, people that are having migraine and that are also taking OCP, is there anything we need to note about them? They are at increased risk of stroke. Like, say it out, shout it, ask your friend, like migraine, because it's not about whether you can diagnose it. You will read the question and diagnose it. There is no one here that will say, I don't know how to diagnose migraine. Usually use pound or something like that. So pulsating, phonophobia and the likes, then nausea from, you can look at the mnemonics and write the whole stuff out. So something like that. So once you see that, you already know that this is migraine. So now you now saying this is migraine. The next thing they now tell you that this patient is taking OCP and the patient is also a smoker. And now say, what's the best next step? The answer is going to be advise that patient to stop, to change the OCP. You want to change the OCP to maybe something that just involve maybe something like levonorgestrel or depending on whatsoever the patient is using the OCP for anyways, or something like that does not contain estrogen basically. So it might be an implant that's related to progestin. Just remove it or change it. That might just be all. So you now rehearsing and know that in the exam, it's not just about you saying, is it migraine? Is it tension? Is it cluster? No. You've left that level. It's just for you to know, what do I, you just look at the patient and be like, now this your migraine, what do I need to remember? If the question is the patient is taking OCP, the patient is a smoker, you want to counsel the patient, life, in fact, just changing of OCP to another one is going to be the correct answer. Like the best next step. Someone just coming, just go and change the the contraceptive method. All right, so that's the first thing. So the next set of questions is about the treatment basically. So now this is the treatment. The treatment you have, we have the abortive. That's it. The patient is definitely having it. Then we have the prophylactic, just to prevent it. So now this abortive now, I know if I ask now that what is the treatment for migraine, everyone will be shouting, Sumatriptan, oh sorry, Dr. Suma. I doubt if that question is going to be about sumatriptan. Completely doubt it. Like, you choose sumatriptan, you are wrong. You are most likely going to be wrong. Now let us look at each of them very well. I wrote one rubbish here. I just wrote NTM. I think this sounds like a particular network service in Nigeria. MTN. But you look at it from N back towards N back to M. So once you come here, you see the question about migraine, just write, I know, so something like NTM. This is what you are taking into the exam of. Now look at it. So if you look at that question, the patient is still having it actively. Which drug do you want to give to the patient? Actively having it, is coming, having the. So your answer is going to be NSAID until proven otherwise. You just say NSAID. NSAID. If the question says the patient has used NSAID and the patient is no more responding to it, what's the best next step? You now go to triptan. Can you see how you are moving? So the focus basically should actually be this triptan, but you don't jump to triptan like that. So it's more of, you start from NSAID. So usually NSAID should have been given before you just jump to triptan, which is opposite to what most people used to do. Once people that have migraine, so some people just jump to this. They just jump to triptan. Now, the last question here, under this abortive, no, second to the last. Second to the last. This patient is having, you look at the question is migraine. The patient is now having a lot of nausea. He's having a lot of vomiting. They now say, what is the best next step? If you go for NSAID, you are wrong. If you go for triptan, you are wrong. The answer will be metoclopramide. Can you see the way you are reasoning in the exam? That is the thinking you are taking into the exam. It's not just about being it's just migraine they are going to. You are going to be solving puzzle. So you look at that question and be like, has this question been given NSAID? And I'll say no. The answer will be NSAID. The patient is no more responding to NSAID. What do you want to give? The patient is still having it. He's still having the headache. That's why they say the patient has used NSAID at home, blah, 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 and the likes. You go for triptan. Your answer, you just check the question and pick triptan. You now check the question. This is someone that is having migraine, having a lot of nausea, vomiting, blah, blah, blah. Now say, what's the best next step? The answer is not NSAID. It's not triptan. The answer is metoclopramide. So it is intravenous metoclopramide. You don't give these other ones. If you choose them, you will be wrong. All right, so we've aborted it. So this patient has been having it for long. When you read the question, you are now saying 4 weeks. 4 weeks. The patient has been having this headache for 4 weeks now. It's not likely the patient is still having it at that. When you start seeing that kind of question, that question is most likely about prophylactic drug. People don't have headache continuously for 4 weeks like that. They will have come to the hospital. This patient, you read the question, the patient has been having this kind of headache for about 6 weeks. The answer, what's the best next step? The answer is most likely revolving around prophylactic drug. And the most tested one is beta blocker. This is the one they are most likely going to test, this beta blocker. You see this valproate, they are most likely not going to test it. You see this topiramate, they are most likely not going to test it. So when I was talking about metoclopramide, I said that will be second to the last point. The last point here is this. The patient has used NSAID, not working. And this patient is not really vomiting. It's not even vomiting. The patient may be having nausea, but not vomiting. The patient has history of myocardial infarction. What is the best next step? You look at it. The patient is no longer is no longer responding to NSAID. The patient is not vomiting, so I'm not going for metoclopramide. And I'm like, which one do I now want to go for in this? No longer responding to NSAID and the likes. So you can't give triptan for this patient. So you may be thinking towards just paracetamol. You may be thinking towards just paracetamol for all you care. You just look at the option and just say, they've never tried acetaminophen. Acetaminophen in Africa is not the same as acetaminophen in US. So the potency is actually differs. So don't underestimate its power. So I say just give acetaminophen and the patient may be all right. So please never forget, once there is MI history, you don't give triptan. All right. So that's just this and this. I wrote something here. Acetaminophen is the first line treatment for acute management of severe migraine in pregnant women. In pregnant women, the abortive drug you want to use for them, acetaminophen. Why? NSAID may be dangerous to them, It can actually reduce the production of prostaglandin that should keep the ductus arteriosus open. Prostaglandin E1 and E2. So you need to look at it holistically. And the likes. So just for you to be aware. So that's the first line in them before you start coming down. So you don't go for NSAID. You just go for acetaminophen. Pregnant women. Prophylactic, beta blocker. These are the others. Valproate, topiramate, TCA. These are just the others, which they don't usually revolve around. They just answer around beta blocker. Just know the beta blocker and leave the rest. Just be like prophylactic. When they ask me, I just pick beta blocker and leave and forget about it. Look at it simply so that you don't Because once you start putting a lot of jargons, after a while, they won't make sense to you again. When you read question, you now be seeing too many answers, and you are now going to be confused. That which one do I pick? This is the only one I know that we need to tear it apart for you to understand it better. So we are done with that. So this is another drug you may want to just say you've seen it before, erenumab, which blocks CGRP action and has a prophylactic role. Okay, so that's just for the migraine. Can you see? You diagnose it, then you come here and treat. So this is where most questions will come from. Just rehearse this, our anemone, pick a sheet of paper, write it down, like say it to yourself the way you will treat it. Like the first one is NSAID, then if they say NSAID is given, I'll go for triptan. So just something like that, something light. What about the cluster headache? The cluster headache, there's no one here that will say I don't know it. What you will see in the question that will tell you that this is cluster headache is actually autonomic symptoms. You are most likely going to see autonomic symptoms. Conjunctiva, this is someone that is having a headache. You are now seeing conjunctiva injection. The eyes is looking red. You are seeing nasal. You are seeing nasal stuffiness. You are seeing lacrimation. You are seeing rhinorrhea, lacrimation, conjunctiva injection, ulnar syndrome, and the patient is having a headache. Your answer is cluster. So you will definitely see something related to autonomics in the question. Definitely. You may even be seeing vagal nerve pulse, something that is related to that. But once you are seeing that, you know that one of the things you want to do is to go and check the brain. Hope you are not dealing with space occupying lesion. All right, so that's that. Now look at the diagnosis. So what do you want to take with respect? Because this one involves something related to nervous system, autonomic symptoms. You can even see palsy, particularly nerve palsy in the patient. So you need to be very, very careful. You may, for all you care, you may just be dealing. You may be dealing with a space occupying lesion. So when you see, sorry. So when you read the question and you see headache, conjunctiva injection, you now see cranial nerve involvement. You want to be sure that there is no. If they now say what's the best next step, MRI straight. MRI straight up, straight. You just want to do MRI. They say why are you doing MRI? Because that cranial nerve involvement that you are seeing, you want to be sure that it's not from space occupying lesion. So never forget that fact at all. So MRI, just to exclude structural brain lesion, and also if at all you are dealing, this is the first time the patient is having it, so you know that you've never had this kind of headache before. So you imagine someone that maybe someone that is around you, you know, realize this person just suddenly start having headache, just shouting, I'm having headache. Now look at the patient. The eye is red. You are seeing facial asymmetry. Will you tell that patient to go and pick? You be using paracetamol? You won't say that. Be like, this headache, I don't think it's, even if it's ordinary, but you be like, let's go and infect. Let's go to town with it. So it's actually what you will have done. So, and that's that. Carotid artery dissection, we'll look at it later. Cavernous sinus infection, we'll also look at it later. Now, apart from diagnosing it and best next step, which is MRI or something like that, unless the question says it has been done. Now say what's the best next step in terms of treatment. The most tested in the exam is high flow oxygen, 100% oxygen. This is the most tested. The one I put the arrow on here. This is what they will ask in the exam. This is what they ask. Sumatriptan injection, they hardly test it. You see this 100% oxygen. That's the treatment, acute treatment. So if the patient is still having it, they will write option A, 100% oxygen. Option B, sumatriptan. Some people will now come out and be shouting, I don't even understand them. The two options are there. They are there. High flow oxygen, sumatriptan. The two of them, option A and B, I don't even know. I just choose sumatriptan. Oh, I choose high flow oxygen. The answer is high flow oxygen. So is after this is the first one that you just focus on this. Like unless it's not there, that's when you go for triptan. So to now prevent for prophylactic for this one, the answer is verapamil. Usually they prescribe it with prednisone. So verapamil typically prescribed with prednisone. Now let me now show you how they can put it. So to prevent this kind of headache in the patient, option A, and now say verapamil. You just say verapamil. Option B, you check, you now see verapamil plus prednisone. So I will advise to go for verapamil plus prednisone anyway. So, but in case they do not remember to put prednisone, you just go for ordinary verapamil. Just don't forget verapamil for prophylactic. Tension. So all those injection and the likes, oral, you won't see them. You won't see all of them in the headache. So most likely is related to stress. So I have it. In fact, the break we had now, I just needed to just give myself paracetamol because I was just having a headache, but my own is just due to stress. So because every single time you see us sit down here and just say let's have webinar, we are not just for meeting what we feel like we pass through days when we see put out before we even put out the flyer, we'll have passing through days of like what are they going to ask. This one, sleepless night. Yeah, I know you also pass through sleepless night, but they differ. You can choose, but we must go through everything again and be like, yeah, people must get the gist of what is going on anyways. So if I thought we now produce some videos and some people are now sabotaging all those efforts, all I know is that life has a way of actually God has a way of fighting for someone anyways. So this is first aid we are using for you, but I don't think there is any time we tell you not to go and buy first aid. We even tell you to go and buy the first aid. So go and buy the first aid. When people call and they say which question bank will I need, I will tell you go and subscribe to your U-word. Like do this, get that, go get all this one, sit down and now be going through them. Not that you don't need first aid again. Who told you that? Won't say that. Anyway, that's just by the way. So please don't look down on us in any way. We know some of you are actually older than us, but at the same time, don't look down whichever efforts we are putting into this stuff. So sometimes when we are talking, don't let us mind the tone with which we talk to us. I think we are doing far more than what you can actually imagine. Like far more than what you can imagine and the likes. Sometimes we'll sit down and cry and be like, well, why are we even doing this? Like sometimes we just want to give up, but the next thing we see is a flyer is out again. You just keep pushing. So encouragement here and there, they actually keep, because if we chose not to do it, maybe you have passed already 1 and 2 and different, and we just close down the whole of Concept Academy. What about those people that are coming? That's going to be a selfish idea. So encouragement will also go a long way. Even if it's useless to you, someone is going to actually it might actually be useful to someone. So you don't want to discourage the people that are doing, no matter the efforts and the likes. So that's just by the way. Tension, headache come with stress, a lot of stress. In preparing for exam, you pass through stress. So just stress. So when you look at the question, you won't see all these what do you call it, oral injection. You won't see all those stuff there. Just so I give it a name, which I hope in the nearest future, if I have the opportunity to stand before the whole world and talk about headache, I will call it a naked headache. Actually, I'll just say this, I call this naked headache because you don't really see anything in it, just headache and headache. So what is the treatment? Yeah, the treatment they are going to ask in the exam, you need to be very careful, because when we are stressed like this, we just pick paracetamol and use. So, and some people just use NSAID. All right. Now, in that question, you need to be very careful that that question is not about if they just say what's the best next step. So your answer is actually relaxation, massage, hot bath, avoidance of exacerbating factor. If the patient is not sleeping well, sleep. That's why sometimes when you are stressed, you're having a headache. Just you sleeping alone can actually make the headache to disappear. So relaxation too, massage. So in the exam, you may be surprised that this is just what they are testing. So if you now check, and this is not about non-pharmacologic, they now say pharmacologic, the answer is going to be NSAID and acetaminophen. NSAID and acetaminophen. NSAID and if by all means you try to see that and there, you see one of them that's option that's having hand, pick that and get out. That's the best answer there. But if you don't see that, you see NSAID, you see acetaminophen, you go for acetaminophen first. So, but the thing is NSAID and acetaminophen. What are secondary headaches? Secondary headache. So you now understand how they can test this, relaxation and the likes, then the treatment. Secondary headaches. How you will know that this is secondary headache is that you will see red flag. So if I will advise you, you just want to know the red flag and get out. So what are those red flags? This is the first time this person will be having a headache. The person is shouting, "This is the worst headache of my life," and is suddenly starting. This is a red flag. It's not ordinary headache. It's not caused by all those migraine and all those guys. That's not your concern. So it's another thing entirely. You are seeing money for meeting, nocturnal headache. The patient is less than 10 or greater than 65. Neurologic sequelae, you are seeing them there. You say these are all red flag. Red flag. So when you see red flag in the question, so you need to actually go to town, check that question and bring out which one. There will definitely be a clincher to whatsoever the patient is having. Now, focal neurologic sign, symptom, papilledema and the likes. So, headaches subsequent to head trauma. For those that have watched Resident, this patient had trauma. Just walk into the hospital. Not bleeding from anywhere, no bleeding from the nose, no scratch, nothing. You just walk to the hospital and now say, we just had road traffic accident there. I'm also one of the. Just say, okay. The nurse just say, "Wow, you feel?" Just say, "I'm only having a headache." And that nurse now said, "Don't worry, your own is not bad. Just go and lie down there." So later, I think that patient eventually died. So headache subsequent to head trauma is a red flag. Likely that patient is bleeding. Likely that patient is having intracranial hemorrhage. So please watch out for this in the exam. Just erase red flag. So all those ones with red flag, once you see them, you now investigate them. So if you are suspecting subarachnoid hemorrhage, you go and do CT without contrast. That's the answer. So if you do that, what do you call it? You do that, CT is negative. That's when you go for lumbar puncture. So there is a rule you are going to take into the exam, and that rule is that you must never do lumbar puncture before you go and do CT. You don't do that. It's wrong. Most of the time, you first of all do CT before you go and do lumbar puncture. So most of the time, that's what you do. Just to be sure that there is no, because if you go and do CT, if you first of all do CT, you'll be able to know that this patient does not have anything that can make the patient to cone. Then you can now go ahead and do the lumbar puncture. So please never forget this rule. These are just clinchers you take into the exam for some conditions. Because subarachnoid hemorrhage now and the likes, you are suspecting it. That's what you want to do. And the next thing some people are going for is lumbar puncture. That would be wrong. You first of all go for CT without contrast. So in the emergency room, what are we going to do for subarachnoid? We'll be looking at this later. So CT of the head is indicated for red flag symptom. And this is just what they want you to bring to the exam. All those stories, they are just so this is what they want you to bring. This main point. This is what you will use. So once you see red flag, that's what's the best next step, CT. Red flag, best next CT. Red flag, best next step, CT. That's just a statement. Someone is less than 10, having a headache, but best next step, just a CT. Greater than 65, having a headache, Best next step, CT. You are seeing headache. You are now seeing focal neurologic deficit. Best next step, CT. This patient is having papilledema. He's also having early morning for meeting and the like. Best next step, CT. That's just the statement they want you to go. They are not asking unnecessary question. So the treatment will now depend on what is causing it, and that's that. What about trigeminal neuralgia? Now, trigeminal neuralgia, the story that surrounds it is this. They will just say that this patient is having shock-like or stabbing pain or severe pain or some sort of having excruciating pain along the distribution of the trigeminal nerve. Now, what are the distributions? It might be just something related to V1, V2, V3. Just along the distribution of it. All right. There is now something that will give it out. Trigger by things that shouldn't even trigger it. Cold. Minor trauma. Chewing of food. Brushing of teeth. The patient will be shouting, yeah, yeah. Shaving around that side. The patient cannot stay. Just do yeah, yeah, yeah. So once you see that, just a trigeminal neuralgia. So that's the diagnosis. Now, that's not what USMLE2 wants from you. What USMLE2 wants from you, you are now going to check in that question, is it unilateral or bilateral? If it's unilateral, is it truly trigeminal neuralgia? If it's bilateral, and that's what's the diagnosis, the answer is multiple sclerosis. Most likely. So it must be unilateral. You want it to be unilateral. So once it's bilateral, most likely it's secondary to multiple sclerosis. All right. So that's just by the way. In case that's how the question comes. That's how I say if bilateral, multiple sclerosis, nil. Even though you see trigeminal neuralgia as option A, option B, they now say multiple sclerosis. Just see the description is fitting into trigeminal neuralgia. What you want to check for in that question is it bilateral or unilateral? If they say it's bilateral, just go and pick multiple sclerosis and go. It's just about is it unilateral or bilateral. All right. The next thing is basically the what do you call it? The treatment. The treatment. First line treatment, carbamazepine. So they know everybody knows carbamazepine, but that's not what they are really going to put in the option. It's this oscarbazepine they will put there. This oscarbazepine is what they will put there. So watch out for this oscarbazepine. So you don't say that there is no drug like that. Carbamazepine, if they give you, good. If they don't give you, oscarbazepine. So please never forget this oscarbazepine. I notice this is the one they test most of the time. So please just watch out for this in case it's given in the exam. You know that, wow, I think I get it right. Oscarbazepine. So if at all the patient has used this drug, the patient is still having it, what do you want to do? Surgery. So with surgery, microvascular decompression, because usually is actually due to a fessel. So we usually say a fessel that is compressing on the trigeminal nerve. Do you get it? So usually due to a fessel compressing on the trigeminal nerve. Usually, so you just go and do microvascular decompression and rhizotomy. So, but I doubt it if they are going to get to this level. But if at all you can pick it, pick it. So if I thought they are going to get here, they might just say, what's the best next step? The answer that the patient has used carbamazepine, no response, or no significant improvement, or carbamazepine, no significant improvement, any of them. What's the best next step? You just say surgery. The answer will just be surgery. So they might not even be asking all these names. So before you give yourself a headache, think lightly. So and if I thought you are like, I get into the exam, they are now asking me about the name, and that guy was shouting, they may not. Just speak something related to vascular decompression. That's all. Just speak it. Microvascular decompression. Because that compression is actually secondary to a fessel. So we are done with that. Then we come down to the TIA. Transient ischemic attack. There is no one here that will say I've never heard of TIA before. It's a lie. In fact, I will say it's a complete lie. Everybody knows TIA. You have an idea of what is in TIA, what is going on there. Sorry. So TIA is just this transient. It's sudden and it's transient. It comes and just briefly within few minutes it goes. So basically or generally, So, though it can last up to 24 hours, but within few minutes, it just comes and it goes. Neurologic dysfunction that's usually caused by focal brain, spinal cord, retina ischemia without acute infarction. So, it's just a TIA. It's not a full-blown stroke. We call it in Yoruba. We used to say make a statement in Yoruba language. We say kese keseleri kasa baba kese kese mbolo no. So what does that mean? That you are only seeing small thing. The bigger one is likely to be coming, and that is where your thinking is going to be pegged on. What is that bigger one? Full-blown stroke. You see, TIA, that question, what they want you to bring into the exam is that the patient only developed TIA. The next time you are going to be seeing the patient, it might be a full-blown stroke. That's the statement you must never forget. That's why they put it here. The highest risk for stroke is on the day following the TIA. Do you see? On the day following the TIA, a risk estimated with this ABCD2 score. So we have what we call the ABCD2 score. Let me show you the ABCD2 score. A there is just the age. So you can see when the patient is at least 60 years. So that's A. Blood pressure is also high. That's for B. Blood pressure. Systolic blood pressure more than, at least 140, or diastolic blood pressure at least 90. So then, clinical features. Speech impairment only. Unilateral weakness is also in what the patient experienced during that TIA. You just be looking, just list them out. A, B, C, D. 2. D2 is talking about 2D. So D here is about the duration. Is it between 10 minutes to 59 minutes? So, or is it at least 60 minutes? Is the patient having diabetes mellitus? So, just A, B, C, D2. You can practice around it. You can close your eyes and just say A is age, B is blood pressure, C is clinical features, D is duration, and second D is diabetes. So, look at the one that are 2. The duration is more. We say this is transient, but this is already more than 1. It's already at least 1 hour. So, that is 2. Then look at the weakness. I'm already seeing something that look like stroke here. Lateral weakness is also 2. Can you see? So when you are getting a score of 0 to 3, that's low 2-day stroke risk. So that the patient is most likely going to have stroke within 2 days is very low. Score of 4 to 5, moderate 2-day stroke risk. So why score of 6 to 7, high 2-day stroke risk. Most likely the patient can develop stroke within few days. So that's just ABCD2 score. So you can practice around it, like get used to it in case that is actually they give a scenario that's around that. All right, so that's just by the way. So what of the pathophysiology for it? The pathophysiology is related to this embolism, lacuna, small vessel obstruction, low flow enlarged. So these are just statements. I'm going to summarize them for you. How are you going to diagnose it? Now, when they give the story about this patient, I'll show you a question. So you see, have an idea of how it can come. This patient was just sitting down or was just eating, just experienced this within 5 minutes and the thing resolved. So once you see something like that, you're like, okay, this is looking more like TIA. You shall put on examination, the patient is having this one. That's what's the best next step. The best next step is to first of all rule out stroke in that patient. In the exam, the best next step is that case that you saw. You must rule out that stroke. Hope this patient has not developed stroke that is going to just manifest very soon. So the answer is going to be non-contrast CT. That's the best next step. You just see something related to TIA, and that's what's best next step. They never said non-contrast CT has been done. Question never mentioned that. The only thing is the scenario, and that's what's the best next step. Your answer is going to be non-contrast CT. Don't go for any other one. It's just going to be non-contrast CT. Just pick that and you're fine. All right. If the non-contrast CT is not there, possibly MRI may actually help. But non-contrast CT is the first thing. That's the answer. If they put both non-contrast CT and the MRI there, the answer is still non-contrast CT. If you look at it, I'm shouting non-contrast CT on top of my voice. So which means that if they give question on TIA, that's what's the best next step. You now go and pick another thing. You must be a joker. because you are definitely going to get that question wrong. So the answer will be non-contrast CT. If the question now say non-contrast CT is done and they are not seeing anything, what is now the best next step again? The answer will now be to rule out the causes. Am I dealing with something related to the heart, or I'm dealing with something related to the carotid artery? Those are the two basic ones. Am I dealing with something related to the heart, or I'm dealing with something related to carotid artery? So if you can, let me say they give you the story. This patient had TIA. Non-contrast CT is done, nothing. But when you check the vital sign, they say the pulse is irregularly irregular. Definitely this patient is most likely having atrial fibrillation. Then the best next step after the neuroimaging is going to be echo. A clincher has been given. Oh, they give you the question, TIA, scenario, non-contrast CT is done or neuroimaging is done. They are not seeing anything there, so they know it's not stroke. They now tell you that on examination, they are hearing carotid bruise. They now say, what's the best next step? The answer will be duplex ultrasound of the neck. You want to see how narrowed those carotid vessels are. Because if they are very narrow, the next thing you see is stroke, and the thing may even be dislodged. Whatsoever atherosclerosis that is there, atheroma that is there may be dislodged. So that is this. Causes echo or ultrasound. That's how you'll be looking at the question. So it's a battle of, can I see anything that related to the heart in this question? Can I see anything that related to the vessel in this question? They will put in the amidst the option, you will see something related to, you will definitely see something related to echo. You will see something related to duplex ultrasound there. All right, so this one is actually about echo. So look at this 65-year-old woman comes to the medical department for transient weakness, just a transient weakness. She experienced muscle weakness in her right arm and leg this morning that lasted approximately 20 minutes and has since resolved completely. So this patient is fine now. And as the patient has had no headache, vision loss, blah blah and the like. She has never before had similar symptoms. Medical history is significant for hypertension, diet control, type 2 DM. The patient underwent mitral valve replacement with a bowel prosthetic valve 5 years ago due to mitral valve endocarditis. Now, so she is a lifelong non-smoker. Blood pressure is fine. Chest examination, pulse is 65 and regular. Blood pressure is 131/70. Chest examination is unremarkable. Neurology examination review no muscle weakness. ECG, complete blood count, renal function is done. In addition to neuro imaging study, which of the following is the best next step? So you have two things you are thinking about now. You want to check the carotid artery. You also want to check the heart. All right, but they gave you something here, a clincher. You are like, this patient had mitral valve replacement with a bowel prosthetic valve 5 years ago due to mitral valve endocarditis. I hope we are not already having some vegetations around these guys. Do you get it? So you're already thinking, I'll be like, okay, the next thing I want to do is to go and do echo. Just pick echo and go. Very easy, straightforward. So your answer, your thinking is just to be like, okay, which clincher are you giving me? So that you won't get into an exam and be shouting, they put ultrasound, they put echo. Which one do I choose? I don't even know. All you need to do is just to look at the question. You are seeing something related to the heart, you go and do echo. You are seeing something related to the neck, or they are even telling you that the patient has renal artery stenosis and this patient has TIA. Then the next thing you want to go and do is to go and do duplex ultrasound. If the renal artery stenosis is due to atherosclerosis, then most likely you have atherosclerosis in the carotid artery too. I don't know if you are getting it. Stop.
Yes.
I'm talking to myself. Dr. Adioba.
Sorry, that's me. Sorry about that.
All right. So, but now that's just for you to have an idea of what is going on here. Now, the next thing is about the treatment. You have already done the best next step to rule out stroke. So when you are revising your TIA, ask your friend, what is that thing you must, the question is, you must first of all focus on that, hope this is not stroke, hope this is not stroke. So the answer, best next step to that will be non-contrast CT. Do you get it? So if that is established, you now go for best next step is now to look for the causes. So for you to know what is causing it. So the next best step we want to talk about now is about the treatment. So now you want to check with respect to this, area, if the symptoms are ongoing and potentially disabling. They say the symptom is still ongoing, and is so most likely you may even be dealing with stroke. You may actually be dealing with stroke because it's still ongoing. So your best next step is going to be intravenous thrombolytic agent, which may just be Otiplase. Just look at it and pick Otiplase with thrombectomy. So that will be your answer. Can you see? That's the answer. So if the symptoms are already resolved or are ongoing but it's not disabling, so it can be thinking, you can evaluate it further with MRI or neurovascular imaging to just rule out stroke. So please never forget this. All right. Then, because stroke is your focus, so if this patient is going and or whatsoever that child is now asks you that, what do you want to place the patient on, and different kind of thing like that. So you want to place the patient on antiplatelet therapy just to reduce the risk of future stroke. If the patient is hypertensive, you actually need to control the hypertension better. You remember the ABCD2. If the patient is diabetic, you also want to control the sugar better. So these are the things you do for them when they are going. If the carotid artery is narrowed, you go and do carotid endarterectomy. That's all. So when you solve questions, all those questions, you'll be able to see the way they play out. Now, we've seen Omode stroke. Now we want to see the Agbalagba stroke. Now, the big guy called stroke. Now, I want you to just get the gist around it and move on. Pick few points you can pick. The rest, drop it. They may not ask you any question on anything. Yeah, for all you care. So just be happy. Be okay. Revise it by yourself. Pick your first aid. Revise over and over and over and over again to the point that you can easily close your eyes and say, this is what I'm. So anyhow they now twist the question, you can make a guess. Even if you get it wrong, God has a way of crowning your effort. Like, you just know that you still pass and pass very well. So these are the two forms of stroke. Basically, we want to look at ischemic and hemorrhagic. So now, these are the modifiable risk factor. These are the non-modifiable risk factor for stroke. In the exam, what is the factor USMLE wants you to focus on that they are going to ask in the exam? That what is the which of the following is the most likely, the highest risk factor for stroke in this patient? You see it. If it's modifiable dimension, the answer is hypertension. The answer is hypertension. It's hypertension. They are you see, go and sit down and be cramming, live the way a coach should. You are just deceiving yourself. Which coach should are you going to remember in the exam? Just come here and pick hypertension. That if they ask me anything about this factor, yeah, hypertension, I will pick it and get out. If it is non-modifiable risk factor and they ask you about the risk factor that you must pay attention to, the answer is age. The answer is age. Age for the non-modifiable risk factor, hypertension for the modifiable risk factor. Just those two. So what is difficult there? Just rehearse it, say it, because you can easily forget them. We are done with that. Now we come down to the atherosclerosis, then hypertension, chronic hypertension, hypercholesterolemia, diabetes. Atherosclerosis, most of the time, you see it affect the extracranial and intracranial vessel. It can affect them. So why the chronic hypertension, most of the time, you see it is usually affect the perforating vessel. I will show it to you. So we have what we call perforating vessels in the brain. They are deep vessels in the brain. You see them in deep regions. So the kind of stroke, the kind of infarct you see that develop here is lacunar infarct. The kind of stroke you see that comes here is lacunar stroke. With this, so when they show you a lacunar stroke in the exam, which I will show you everything, they show you lacunar stroke, they just ask you what's the risk factor here. The answer is hypertension. Hypertension, risk factor, hypertension. You can see it as many times as you like. It's still going to be hypertension. They will test. They are most likely not going to test anything on hypercholesterolemia. They are most likely not going to test anything on diabetes. Hypertension, 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 hypertension. We can't shout hypertension like this. You now get into an exam, you are picking diabetes. Even if you are sleeping, you hear it from your sleep. That guy was shouting hypertension, 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 hypertension. For all those atherosclerosis, you see, they can affect extracranial fistula, they can affect intracranial. Then we are done with this area. We've picked what they want us to pick. Then you come down to this area. How those stroke will manifest. The way they are going to manifest is this. Now you are going to be looking at it in the exam. You will check that question. Just get the picture, the mental picture in your head. Let me use my tracer here. All right. If you check the question, you are seeing motor is lost. Sensory is also affected. You are most likely dealing with cortex, cerebral cortex. So you will be thinking more towards, am I dealing with anterior cerebral artery? Am I dealing with middle cerebral artery territory? So if your answer is going to be anterior cerebral artery, you will see this is going to be related to lower limb. If your answer is going to be middle cerebral artery territory, you are going to see it's going to be related to the upper limb, also going to be related to the face. So, but in that question, you will see something related to the motor manifestation. You will also see sensory manifestation. So you will see something like contralateral paralysis and sensory loss. So that same limb that is affected, let us remove our mics. That same limb that is affected, so that same limb that is affected, you are going to see motor and sensory in that same limb. So your thinking will now be, which limb? Is it lower limb? Then you are most likely living with anterior cerebral artery territory. And there is one more thing that comes with that anterior cerebral artery territory that is supplying, and that cortex that is supplied by the anterior cerebral artery, is they usually come with urinary incontinence. So you see urinary incontinence too, that they are going to come with. So what about the middle cerebral artery? Is definitely going to be related to all these upper limb. Is also going to be related to the face. There is one more thing that is going to be related to, and that is actually the what do you call it? The visual association cortex. You are going to see is going to be affected. All right. So if that is the case, if the thing is affecting the non-dominant hemisphere, you will see the question will come with neglect syndrome. If the thing is affecting the dominant hemisphere, you will see the question, the patient is going to come down with something related to aphasia or Jesman syndrome. Dominant hemisphere. You call all these things cortical signs. You will just see something related to cortex. Cortical signs will be there. Motor and sensory I mentioned. I never say motor alone. I never say sensory alone. Motor plus sensory. All right, we are done with that. So just check if they say this patient is having weakness of the right upper extremity and sensation there is also reduced. You already know that you are dealing with cortical lesion. So if that is the case, now say which artery. So just check this, right? So there is a lesion on the left cerebral hemisphere. If that is the case, what else will the patient present with? You are most likely going to see something related to aphasia. You are also most likely going to see something related to Jesman syndrome because it's dominant hemisphere that is affected. All right. Come down to the posterior cerebral artery. What we give it out is what we call macular sparing. They will just talk about the patient can have this homonymous hemianopia with macular sparing. We can be looking at that later. So just say, oh, this is posterior cerebral artery. And it may be related to the midbrain. That's where you have the Weber syndrome, midbrain. So you just see, usually the medial part of the midbrain, you just be like, okay, this is most likely dealing with midbrain. So posterior cerebral artery. And that's that. So what about the lacunar stroke? I already mentioned something about lacunar stroke. So it's actually secondary to chronic hypertension. They will ask that in the exam. secondary to chronic hypertension. They hardly test this hyperlipidemia, diabetes, or smoking. But in case they ask them, just know they are also there. But the commonest one is hypertension. If they write hypertension and they list the others together with them, maybe option A hypertension, option B diabetes, option C hyperlipidemia, option D smoking, your answer will go for hypertension. Unless that patient is not hypertensive local, the answer will still be hypertension. So how will I know this is a lacunar stroke or a lacunar stroke? The way you will know is that you will just see only pure motor. So when you check that question, you just see the only thing you are seeing there is just motor. You will not see sensory. So the only thing we see here is motor. Weakness. That's the only thing you see. You will not see anything sensory there. So once you see that, you just be like, most likely I'm dealing with lacunar stroke. All right. So that's that. What about these other guys? Posterior inferior cerebellar artery. So posterior inferior cerebellar artery is supplying the lateral part of the medulla. So you call this lateral medullary syndrome. Can you see? So if it's lateral medullary syndrome, what are the cranial nerves I have at the lateral part? You'll be like cranial nerve 9, cranial nerve 10, cranial nerve 11. So you already know what the patient will present with respect to those cranial nerves. What are the tracts I have at the lateral part? You have something like sympathetic nervous systems, spinothalamic tract, spinocerebellar. Can you see them? You just list them like that. So those are the tracts. Then the fifth cranial nerve, you just see the manifestation will come out in the question. So they now ask you which vessel is affected. Pica. All right. And that's just with respect to this. So, and that's what you are going to see here. All right. So please never forget this at all. That's why you are seeing lots of pain and temperature sensation on ipsilateral face and contralateral body. All right. So that's just by the way the question. So this is motor. So what you also see here will now be something related to sensory. You're also going to see something related to cranial nerves. We don't have cranial nerve in lacuna. It's just pure motor, pure sensory, pure motor, just pure. So with respect to the cortex, you will have motor and sensory. You don't have cranial nerve there. You only make reference to cranial nerve with respect to brainstem. So that's why this is like this. So once you see cranial nerves involvement in that question of a patient having stroke, you are dealing with brainstem. If you are not dealing with brainstem, you may be dealing with upper motor neuron. Usually for that facial nerve, commonly. The last but not the least here is this carotid artery dissection. Now, please, I want you to get the gist around the carotid artery dissection. Is it the same carotid artery that we make reference to around the neck? Yes. The same dissection we know in cardio? Yes. So that dissection is now occurring in the carotid artery? Yes. That's what is going on. All right. So what this patient will complain of is sudden onset of headache, neck pain. You can now be seeing Horner syndrome too. You can see something like Horner syndrome in the question. So then the premise with which the question is given. Can we mute our mics, please? Please, just help us to mute your mic. Yeah. So the premise with which the question is laid down is also going to help out. So you are reading this question, patient about stroke. You can see stroke. They now see the patient had neck pain. He's having neck pain, stroke, carotid artery dissection, straight. Just go and pick it. You don't need to read the finish. Carotid artery dissection, if this is all just about diagnosis. This patient is brushing his teeth, now injured, now develop neck pain while brushing the teeth. You know the way we used to brush our teeth, if you are brushing it aggressively, that suddenly the toothbrush will just go inside. And I say, my mouth. The thing can actually affect the carotid artery. So the now see the patient was doing that, a child was doing that, and now develop weakness. Now develop headache, all manner of stuff. Anyhow they put it, you just know I'm most likely dealing with carotid artery dissection. So giving right to whichever stroke the patient is having. And that's that. It might be restless. They say this patient received a punch around the neck and the patient now develops something like stroke, you just know you are dealing with carotid artery dissection. So that is affecting that carotid artery. So that's how you look at this. So you don't need to cram it. You just think around neck and mouth stuff. This patient is doing something in the mouth, and now maybe brushing of the teeth. Now injured it. Now develop something that look like, develop pain in the neck, headache, stroke-like symptoms, and like you start thinking towards carotid artery dissection. So you don't need to sit down and know everything about it. Just look at it. Now, the next set of questions is actually about the drug you are going to give to the patient. So, if the patient has low bleeding risk, you check through you don't see any reason why this patient should be having bleeding. So your answer is going to be parenteral anticoagulation with heparin. So heparin is your answer, followed by oral anticoagulant, or you just give dual antiplatelet, aspirin and clopidogrel. So that's that. DAPT, low risk of bleeding. If the patient has moderate bleeding risk, your answer is going to be DAPT. That's your answer. DAPT. Or antiplatelet monotherapy, maybe aspirin or clopidogrel. So that's moderate bleeding risk. So if the question is all about what do you best next step and is related to the drug, so just look at this and be like low bleeding risk. I'll just give the patient heparin or oral anticoagulant. Followed by oral anticoagulant or DAPT. If it's moderate bleeding risk, I will give DAPT or antiplatelet monotherapy. So that's just for some region in the brain that you already know in step 1. So just for you to, that's why we are not sitting down and saying, oh yeah, we're doing it again. It's more of waste of time because we've mastered it. Diagnosis for stroke. Diagnosis. The most tested in the exam. Please don't go and be looking for another thing. We beg you. The answer is head CT without contrast. You just give this. You are like, this is looking more like stroke now. Best next step, head CT. No matter the duration, whether it is 1 minute or 30 seconds, best next step is going to be head CT without contrast. You go for MRI if you don't see anything on CT. You now get into exam, you're like, I saw 2 hours there. That made me to go for MRI. You will be wrong. Best next step, head CT without contrast. Best next step, head CT without contrast. Head CT. So what is there? Because you may think it's ischemic. It might just be hemorrhagic. Now be like, we miss it. Or because you were not following the order. SCT without contrast. It's when they look at the duration, they check the SCT without contrast, they are not really seeing anything appreciably. They can now be like, oh, what's the duration? Let us now go and check the MRI. And that's all. So never forget this. This is the main thing they will test here. This is the main thing they are going to test here. Most other stuff, they hardly test them. Hardly, I say, I'm still going to talk about 1 or 2 of them here, but most other stuff, they hardly. All right. So now, look at what I put here. Initial test here. Non-contrast CT. That's the answer. Even if it's 1 minute, 1 milliseconds, they give you. This is the answer. Because you may think what you think is causing the stroke might not actually be the one. So please just watch out. This is the best initial test. So once you see, you don't negotiate it. You don't negotiate that. Don't overanalyze that kind of question. Just pick non-contrast CT. You can now be, after you are done with the exam, be arguing with yourself that was I right or wrong. Let the score come out. All right. So we are done with that. The initial test. So later, after you have done that, you are now like, okay, this is actually more of ischemic stroke that this patient is having. You now need to do another test to know which vessel is affected. What will help you is magnetic resonance angiography. We peg it on a particular vessel, angiography. So you just know, is this ischemic or hemorrhagic with non-contrast CT? Is ischemic, you now say which vessel is blocked. magnetic resonance angio. All right. Another test that they are going to do, and I will show you how they are most likely going to bring it in, is glucose. Glucose. For all you care, the question might just be about this glucose. Check blood glucose first. When that patient comes in with the stroke, there is what we call stroke mimic. You think it's stroke. The patient is just, the glucose is just down. The glucose is just down. Glucose, 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 glucose. So the question needs to have said that glucose must have been checked. In fact, we used to say glucose as they are collecting the sample, you are writing the investigation the way we used to do in Africa for non-contracity. Like they must go pari passu. Non-contracity, or you be checking the glucose while you are writing you are filling the form out, or you are entering it on the system. So never forget this glucose at all. So when you see, you already have few things to think about. The rest, just ignore them, because when you start putting everything in your head, you will now be lost in the question, because the question will no longer make sense to you. You are the one that wants to score everything in all the question bank you are solving. You want to score 100, you want to score 99. That's why you're having a headache. Just pick the point, apply it to few questions, and just go and write the exam. And that's it, because those questions you are solving, they are not likely going to even come out. More than 90% possibility. So all you need is just an idea, and the question they will bring. So those people that have written the exam and that have passed, you think they knew everything? That's why they were having 250, 260, 270? No, that would be wrong. You are making a wrong assumption. They might not even really, some of them might not even really know neuro as such, but they still pass. So just look at it simply and you'll be fine. So, and that's that. So this is the next thing. We are focusing on this glucose very well. All right, we've talked about the MRI of a thing. Now, we want to determine the cause. What is causing it? We already know the vessel that is blocked and all manner of stuff. What is causing it? Is it cardioembolic from the heart? Is it thrombotic from the carotid vessel? So are there other things the patient is having? Just the same way you were looking at TIA. So but here they are going to give you the image. So they will give you the image. So you go for cardioembolic. Sorry. If you are seeing multiple places being involved, it's more or less like the heart is showering emboli into the brain. So you see multiple places there. You just see they will give the brain like this. You just see lesion here, lesion here, lesion here, lesion here. Just multiple places, lesion here, lesion, all manner of lesions. But once you see them, just be like, most likely you're cardioembolic. All right, so you need to go and do echo. For thrombotic is just going to be like this. It's just going to be like this. One big area will just be affected. So it's more or less like a big valve vessel. It's actually blocked. So you'll be thinking towards thrombotic. Likely single region is what they will show. So carotid ultrasonography. And that's that. In hematology, I think I show you about all those hypercoagulable states. So the question may just be related to it. And that's that. What are the contraindications to, because immediately you see that, you finalize your patient, you are like, which I will show you next. I will show you how you look at this. So you are like, you need to give your this patient thrombolytic agent. So what are those things you may see that we not really want you to give the patient thrombolytic agent? They're actually quite numerous. So what I will advise basically is just to read them to yourself and just move on. When you see it in question, you will know. Holy Spirit will guide you. I know you don't want him, but we'll still tell him to follow you to the You just be like, I think I saw low platelets there. I think this, I think that. Just okay. Prior intracranial hemorrhage is here. This patient recently had surgery, blah blah blah, and the likes. So I know you might have saw some questions where they play around the duration in the exam. Ignore the duration. I'm not saying that's how we do it normally, but you don't just want to give yourself too much headache. Someone has surgery recently. Before you start asking yourself, the surgery that this patient had, where is it? So the surgery that this patient had, is it recently, or is it long, or is short? Is it this or that? You see recent surgery there. So recently, you are seeing it maybe a few weeks, few months. Just be like, I don't really want to give this patient TPA. Something like that. Usually, or the patient has prior intracranial hemorrhage. You want to be very careful. So we just put sample stages. But if this happens, that's fine. If you can cram it, that's fine. If they are quiet, unless you are a neurologist or a neurology or a registrar in surgery that has already mastered this, that's fine. But if at all you are not really used to it, don't give yourself too much headache. Now, what about the treatment? This patient is now need to be treated. We have the hemorrhagic stroke, which we'll look at soon. Ischemic stroke pre-hospital. Management is more of less like first aid and the like. Then when the patient gets to the hospital, what do they do? All right. So don't forget all those non-contrast CT and the like that we were talking about before. So all those things it's not on the road, they will be ordering it. It's when the patient gets to the hospital. The second thing apart from non-contrast CT that I say you will check for, that we are going to, who remember the name? Second thing apart from non-contrast CT you check for in the exam. You start with letter G.
Glucose.
So just check it and just be like glucose. So just focus on that. If the oxygen is low, you may want to raise the oxygen up by giving the patient supplemental oxygen and the likes. So just things that we do normally, but don't forget the non-contrast CT and the glucose to be checked. Now, the next thing is you look at it, all those things are in place. It's now more of what do you want to do for this patient. So if you have a sheet of paper there, and you can write it, which I'm not forcing us to write. So I want to show you how you think around it in the exam without giving yourself too much headache. Just write 185 over 110 BP. So you now put, first, duration. You see there in the question is less than 3 hours. They used to say 3 to 4.5 hours. That's fine. It shall less. So the next thing is you now write the BP. Write this BP 185 over 110. So if the BP they are giving you in the exam is less than 185 over 110 and the duration is less than 3 hours or 3 to 4.5 hours, the answer is 40 place. If the BP they are giving in the exam is greater than 185 over 110 and the duration is still less than 3 hours or 3 to 4.5 hours, your answer is to first of all lower the BP. So by giving clean, this clean here, C here is clefidipine, L here is labetalol, N here is nicardipine. Can you see? Clean. You must note the BP because you want to first of all lower the BP before you place the patient on orthoplace. Once the BP, so in the exam, what you will see they will do is this. This patient that is having the stroke is now, the BP is 190 over 105. Now, as much one of them is greater. It's greater near 190 is high. So this BP is high. Then now see what's the best next step. The best next step is going to be antihypertensive. So you just pick a labetalol. If it's not there, you pick clefidipine. If it's not there, you pick nicardipine. That's the answer. Any of them. So if they now say this has been given, what's the best next step? The answer will now be orthoplace. Don't forget, less than 3 hours. Less than 3 hours. Less than 3 to 4.5 hours. Less than 3 to 4.5. Less than 3 to 4.5 hours. Your answer, that's how you look at it. So you get into the exam, you look at the BP, they give you 175 divided by 105. It's less than 3 hours. They now say, what do you want to do? Best next step. The answer is place. So you need to write this down, get used to it, practice it, say it, and look at it, close your eyes, imagine it. Or else you will just know you know it, drop something very important like this and be pursuing shadow. So this is it. So the next thing is you get into the exam, they give you, irrespective of any BP they are even giving, but the duration is greater than 3 to 4.5 hours. The answer is aspirin, oral aspirin. That's the only thing you can be talking about there. Just oral aspirin, oral aspirin, oral aspirin, oral aspirin, oral aspirin, oral aspirin. So you must rehearse it and get used to it. Now try to use that so that your thinking in the exam will be light and quite specific. So you won't be overthinking. So can you see? That's it. So that's how you look at this whole area. So IV multiplate, you must know when you give it. Duration less than 3 hours or 3 to 4.5 hours. And the BP is less than 185 to 110. If it's greater, you first of all lower the BP. Then you now give the multiplate. But once the duration is greater than 3 hours or 3 to 4.5 hours, the answer is oral aspirin. All these target BP, failed reperfusion, if I thought the reperfusion, don't bother yourself. No one will ask you buy on it. I can bet that with you. I don't see anything on it. Because what they ask, they don't have time to be asking all these too much detailed question. Just something like this, I noticed they just test. Like something. If I thought you solve any question that related to reperfusion stuff and the likes, so it's not something that is common. So pick something light, you know that at least you know something before you start complicating matter for yourself. So when you now master this very well, you still have time. You can be reading the rest and be like, okay, what else and the likes. So that's that. All right. So permissive hypertension is allowed in stroke for perfusion of ischemic area, but patient systolic must be lower than 185 and diastolic must be lower than 110 for you to give this tissue plasminogen activator. So now, acutely, we've started giving something. We've given our multiplate, we've given the patient is looking better. They are like, doctor, if not for you, this man will have died. They say, it's not me, it's God. But doctor, you are the one God used. They say, okay, we thank God. Doctor, when are we now going home? That's the next thing. Be like, all right, you go home very soon. Sorry to just, we have specialists here, but just for us to have a mental picture of it. So now this patient is more or less like going home now. What do you want to do? All right. So you look at all these things. Blood pressure, hypertension need to be controlled. Diabetes need to be controlled. Lipid need to be controlled. You need to place the patient on antiplatelet, diet and exercise. So the patient need to be on anticoagulant. So this anticoagulant now, you need to check. So what you are actually giving the patient. So you need to check what you are giving the patient. It may be, what do you call it, warfarin. You're going to place the patient on. So then for vascular pathology, that is if the thing is secondary to, what do you call his name? If it's secondary to carotid artery atherosclerosis, so the patient needs to be on antiplatelet. So if it's also secondary to carotid artery atherosclerosis that has now caused stenosis, then you need to plan the patient for carotid endarterectomy. You've helped the patient to acutely, but you need to do this carotid endarterectomy. So look at what I put here. I just wrote HDL. So hypertension, DM, lipid, you want to ensure they are better. Sugar is fine. Hypertension is diastolic, blood pressure is fine. Air lipid is also better. So if it's cardioembolic stroke, you are dealing with heart, you give anticoagulant like warfarin. If you are, then you can also give direct oral anticoagulant. So it depends. So if you are dealing with valvular abnormality that is causing it in the patient, maybe mitral valve stenosis and all manner of stuffs, you give warfarin. If you are just dealing with atrial fibrillation that has nothing to do with valves, you give direct oral anticoagulant, which may be something like maybe dabigatran, apixaban, anything, just anticoagulant. So I have been emphasizing one thing since the days of cardiology. In the exam, you go for warfarin, you give warfarin when you are dealing with valvular problem. If whatsoever that is happening in the heart is a valvular abnormality, you give warfarin. So never forget, most especially with respect to atrial fibrillation. So that's for this. If it's another thing entirely, you give direct oral anticoagulant. So never forget that. You don't want to give heparin for long because of HIT. You don't want to give low molecular weight heparin for long because of HIT. So direct oral anticoagulant or warfarin, that's the battle you have. What if the problem that we just solved in this patient is secondary to vascular carotid artery? Then we give the patient antiplatelets. You also solve that problem. How are we going to solve the problem? So if we are dealing with stenosis and that stenosis is greater than 60% in symptomatic patients, we do carotid endarterectomy. If the stenosis is greater than 70% in asymptomatic patients too, we do carotid endarterectomy. So the patient's acute problem has been solved, but this is the next phase. We now need to plan you for surgery, for this, for that, and all manner of stuff. Now let me show you something. So I just put something here that stenosis greater than 60%, but 60% in symptomatic, 70% in asymptomatic. Let me now show you something here. I don't know what I have here, but look at this. So a 70-year-old man comes to the minor department with left-sided extremity weakness of 27 hours duration. I just see extremity weakness, 27 hours duration, and I check the option. This is all about drug. I want to be sure. So what are you asking me? Have you given anything to this patient? They say you have not given anything. I just know this is most likely aspirin because this is stroke. I just look at duration here, 27 hours. It's already more than 3 to 4.5 hours. Aspirin is straight up. So you don't really need to overread the question finish. So now if you look at it, look at all the options. Amiodarone, aspirin, intravenous hydralazine, mannitol, tissue plasminogen activator, warfarin. All the possible answers you could think about with acute and long-term management, they are all here. So if you don't know what you are doing, you will assume that you will be making wrong assumption. Let me read the question finish. His speech is barely understandable, but he seems to be aware of where he is and what time it is. He has a history of record of hypertension and type 2 DM, for which it takes Fasatan and metformin. Temperature is 7.5, pulse is 75, and irregular rhythmicity. So likely we are dealing with atrial fibrillation. In house, the respiration is 16, blood pressure is 175/100. He is fully awake, fully oriented, and cooperative. He has severe dysarthria. So physical examination revealed left homonymous hemianopia, left facial droop, left arm weakness, right-sided strength and sensation and intact. So his blood glucose level is 110. ECG shows atrial fibrillation. CT of the head without contrast is given. So now say which of the following is the most appropriate next step. So they've not even given any treatment at all. So what is the acute treatment? They have brought this patient to the hospital. You just quickly check the duration. That is 27 hours duration. Someone that's having stroke. So if I want to ask now that what kind of stroke do you think this patient is having?
Cardioembolic.
So it's something related to the cardioembolic anyway. That's very fine. All right. So now, if that is the case, so duration is given. They've not done anything. What do you want to do? Give aspirin because the duration is more than 3 to 4.5 hours. That's all. So if they now say that has been given too, they now say what's the best next step? Best next step will now come to all this chronic stuff. This area. What do you say?
I have a question.
I can't even hear you very well.
I said I have a question.
Yeah. So what is the question?
My question is this choice of aspirin. I thought in atrial fibrillation, you give direct anticoagulant. I thought it will be warfarin here.
All right, so that's very fine. Now, that's actually, if you look at what we are dealing with here, it's actually, that's why I mentioned that this is the acute management. Do you get me? Acute, the patient that is having stroke. This is all you are thinking about here. Acute management. Do you get me? Acute, you have acute management, you have more or less like chronic management. Acute management is more or less like, what do you want to do now that the patient is here? Do you get me? The patient is having the problem there. You are seeing it. You don't even know what you are dealing with. You can just see, you already know that, oh, I'm dealing with stroke. This patient is having stroke. For how long has it been like this? Because there are some features that will tell you that this is hemorrhagic. So there are some features you will see that will tell you that this is most likely hemorrhagic. You are seeing maybe headache, sudden onset headache, something like that. You are seeing impaired consciousness and the likes. You start thinking, hope I'm not dealing with hemorrhage, which we are going to get there. So all you see is that this patient is eating and suddenly the patient develop it. And the thing has been like that. Do you get me? So that's more or less looking more like ischemic. The patient is still having it. This patient is coming to the hospital. You've checked the glucose, you quickly do the this thing, the non-contrast CT. What do you want to do for that patient now? You've established that what you are dealing with is ischemic. What do you want to do? So you will be thinking towards, is a battle between Otiplace and oral aspirin here. So when you are now done sorting that acute management out, that's when you now come back down to this long-term management. Do you get me? So you can now be checking, what did we say is even causing it? What is this patient now having? Okay, what do we want to place this patient on? So from what you say now, this patient has been given something. So what do you now want to place this patient? If it's warfarin, if it's what do you call it? Atrial fibrillation. And you now look at that atrial fibrillation. Is it secondary to valvular problem? If it's secondary to valvular problem, then you need to place the patient on warfarin. If it's just atrial fibrillation secondary to other stuff, it's not not valvular, you can place the patient on direct oral anticoagulant. I think I mentioned that. If what this patient is having is carotid atherosclerosis, that the narrowing is quite more, so you'll be thinking towards carotid endarterectomy. That's what you want to do for the patient. So acute management is completely different from chronic management. Do we have someone else that wants to ask a question?
Yes.
Please ask your question.
Okay, it's about the acute treatment, the aspirin. In case if the patient comes with high blood pressure and has a ischemic stroke, and the duration is more than 3 hours, are we going to give the aspirin first or lower the blood pressure?
You just give the aspirin. Just give the aspirin straight. You can
Okay.
now be. So that's one you don't really deal with. What do we call it? You don't really deal with, okay, let me first of all lower the BP before this and the like, because the duration is already prolonged. Do you get me? So you just give. That's why here the only thing is just give oral aspirin and move on.
Okay, thank you.
Yeah. All right. So that's just by the way. So please I think I wanted to show you something. So I think the same thing here. Look at this one. Look at this question here. 64-year-old woman is brought to the mind department by ambulance after developing paralysis on one side of her body and having trouble speaking 5 hours prior to presentation. He now says she has a history of hypertension and experienced MI 2 months ago. She's left-sided. So this is the duration they are giving us here, 5 hours. Can you see? So if you have already mastered your game, you already know that, okay, this is stroke and this is the 5 hours. You just quickly, you don't have the time to, you don't have that patient to read everything line by line. You just quickly trace it and be like, have you treated this patient with anything? They just say no. Which drug do you want to say? Most appropriate pharmacotherapy. 5 hours, just go for aspirin straight. So look at the BP that is given here. she is left-handed. This will answer the question that someone and the second person asked now. Is 190/90. So now say brief initial neurology examination shows the patient is alert, but not oriented to person, blah 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 and the likes. So CT of the head identify large ischemic area beside carotid duplex ultrasound. Bedside carotid duplex ultrasound show complete occlusion of the right internal carotid just distal to the bifurcation. So platelet is okay, glucose is 110, normal coagulation time. So ECG shows irregular heart rhythm. If you look here, you are seeing something related to the heart, you are seeing something related to the carotid vessel. So when the carotid vessel is completely occluded, you don't do anything to it, you just leave it, because the risk of embolus is very low in it. It's not going to break out, or what do we call it? So it won't break out to go to be dislodged. All right, so that's just by the way for complete occlusion. So now they now say she has no known drug allergy and has a negative fecal. And now say which of the following is the most appropriate pharmacotherapy here. You now check this all about you see some this thing there, you can see anticoagulant there and the likes. So basically the way you look at the treatment, 5 hours is giving stroke, just go and give the patient aspirin straight. Just pick aspirin and go.
Yeah, with that, I have a question. Would you want to reduce the BP to below 185/90 before you start the aspirin by giving a better propionisolone?
No. You don't make reference to the BP first. The duration is already long. After the aspirin is given, you can be making reference to the what do you call it? You can be addressing the BP. So the main thing here is just going to be the aspirin. Just give the aspirin and move on. So the only one where you focus on BP first is this one, the Altiplace. Do you get me? So that's the only one you focus on BP first. So the Altiplace. So if the BP is very high, so you want to first of all bring down the BP before you give the patient Altiplace, provided the duration is still less than 3 to 4.5. So if the duration is more, so never forget that basically the most likely question is going to revolve around the oral aspirin, just for you to know which one you are giving, aspirin or Altiplace. After that, you now be thinking more towards something like what do you call it? The chronic management. So the acute one has been done, the chronic management. So if the BP is still high, you address it. You want to place the patient on anti-hypertensive so that the BP will be controlled. The diabetes, you want to control it. The lipid, you want to control it with atorvastatin or rosuvastatin, anyone you want to use. Then if the patient is having what do you call it, something related to the heart, you place the patient on anticoagulant. If it's valvular, warfarin. If it's non-valvular, you give direct oral anticoagulant basically. If it's vascular pathology, you are dealing with carotid artery, platelets, you also look at the degree of stenosis. If it's more than 60% in symptomatic, carotid endarterectomy. If it's more than 70% in asymptomatic, carotid endarterectomy. Let me allow us to go for another break. Wait till before you go, so that when we come back, we look at subarachnoid hemorrhage. So this is fine, anyways. All right.
Please, can we recap the management protocol?
You can recap it. Let me just show you.
Okay.
You can also be recapping it when we go for break, anyways. So management, don't forget the first thing you do when you are seeing the patient with stroke is the first investigation, the most likely investigation that will be tested, non-contrast CT. Never forget that. Then we call it point of care glucose check. So you POC glucose. So in the question, when you read this, you see point of care, you just be like glucose, because they can have hypoglycemia, can give stroke mimic. So never forget those two and miss the rest. So now that is done, you're already seeing that this is actually non-hemorrhagic. So it's ischemic stroke you are dealing with. So the next thing is acute management. Quickly ask, what's the duration? Check the question, the duration will be given. If it's less than 3 hours, you'll be thinking more towards place. But check the BP. Is the BP lower than 185 to 110? If it's lower, you go for place. If it's higher, first of all, bring down the BP, then give the place. If you are dealing with duration more than 3 hours, you go for oral aspirin. So what I advise you to do is just to write this down, like rehearse it over, because the question you will think is one difficult question, and just realize that someone is shouting, I want to lower the BP, you just pick oral aspirin and you just move on. The check the answer, you just see the answer is correct. I'm like, what is, why did you get it? Someone is saying naughty place, you are shouting oral aspirin, and the person is like, okay, it seems as if oral aspirin is the what I'm going to be saying. So you now, another question pop up, you now say this one will be multiple. The person is speaking oral aspirin. You can be like, what is the secret? So just the secret. Just, it may look too short for this to make sense, but you need something light that you can easily remember. So when you are done, so you can be breaking this one down later, but at least get something that you can take into the exam. All right, let's go and enjoy our break. We meet in the next 20 minutes. Thank you, everyone. So, all right. So this is the subarachnoid hemorrhage. There is really nothing about the subarachnoid hemorrhage. Basically, all we need to remember, there are just these two guys. Basically, the circular aneurysm or barial aneurysm, then arteriovenous malformation. So these are the causes. And we all remember thunderclap headache, so it will definitely be in the question. Then we may see neck stiffness and the likes. And when they do lumbar puncture, in a way, you are going to see it will be bloody. So, thunderclap headache, signs of meningeal irritation, I wanted to say, photophobia, nausea, vomiting, and the likes. All right, so that's just by the way. So just like we used to say, if at all you want to diagnose, immediately you are going to do HCT without contrast. So never forget this, HCT without contrast. So just to rule out space occupying lesion. So once you do that, you are going to now do lumbar puncture. So the lumbar puncture, you are going to see, what you will see there is will be bloody. Now in the exam, when you read the question and they say this is a bloody CSF, your differentials is either you are dealing with herpes simplex, virus, encephalitis, or subarachnoid hemorrhage. So you can easily make a guess. So you are thinking towards, this is actually subarachnoid hemorrhage and the likes in that question, and the question might just be going towards herpes simplex. They might even ask which condition is most likely going to give similar lumbar puncture picture, something like that. Or so you may be thinking more towards herpes simplex virus, encephalitis. So don't forget diagnosis, immediate HCT without contrast, then lumbar puncture. So if you rush to lumbar puncture, you are most likely going to get it wrong. So no matter what you are thinking, just know the sequence. It's very easy. Just flow with the sequence. Just be like the same thing we've been saying since. Just flow with it. It makes sense. So usually go for lumbar puncture if the CT is negative, just to look for RBC. That's when you do it. So first one you do CT, never forget. If at all you are still even going to eventually do lumbar puncture, you want to rule out space occupying lesion and all manner of stuff, so that when you are doing the lumbar puncture, the patient does not cone. So what are those conditions that can make the patient to have barial aneurysm that now eventually rupture? Marfan, aortic coarctation, you remember? Because there will be more blood going to the upper limb and also the head and neck. So aortic coarctation. Kidney disease, autosomal dominant, you remember? Polycystic kidney disease, you remember? They are at risk of barial aneurysm. Ehlers-Danlos, connective tissue problem, so and the likes. So what is the treatment they will test? The treatment they are most likely going to test. They are actually, the main treatment is surgery. So the answer, you just check the options, is just surgery. Just pick surgery. This is it. Just surgery, surgery, surgery. So if they don't put surgery, they'll put neurosurgery there. So just neurosurgery. That's all. So sometimes you know that it's surgery. So they may not put these guys there, angiographic coiling, stenting, and the likes. So to stabilize the aneurysm first. So just for you to have an idea. So, but this is the most definitive, because the question will be specific, that what's the definitive management for this patient condition? The answer is surgery. Just a surgery. So even if they put angiography, coiling, stenting, and all manner of stuff, they just know that you are going to be dealing with surgery. All right. So though all of them, you can put them under the canopy of the surgical procedure, but the main thing is actually the neurosurgery. So these are just some procedures they can use to stabilize the aneurysm, so that if at all, what do you call it? There are still some area there that have not ruptured. At the same time, to reduce excessive blood loss, just to stabilize the patient anyways. The next two questions you are expecting, they are about rebleeding and vasospasm. I know you know about pneumodipping, so you need to now get the understanding of how it's most likely going to be tested. So there are two things you are expecting here: the question about rebleeding, the question about vasospasm. So both of them are different, so that you will not be mistaking rebleeding for vasospasm and be shouting, I will give the patient pneumodipping. So if the question says, what are you going to give to prevent rebleeding in this patient? What are you going to do to prevent rebleeding in this patient? The answer is going to be you actually maintaining the systolic blood pressure to be less than 150 millimeter of mercury until the aneurysm has been coiled or clipped. So this is the main thing. All right, so please never forget this at all. So you just need to maintain the systolic blood pressure to be less than 150. So it will prevent rebleeding. So if the question asks, what do you want to give to prevent vasospasm? The answer is going to be calcium channel blocker like nimodipine. Can you see? So all you need to do is just to say, if they ask me definitive, just is neurosurgery. So what can I do to prevent rebleeding? Maintain systolic blood pressure less than 150 millimeter of mercury. To prevent vasospasm, give the patient nimodipine. Now, what is difficult here? And that's all. So you can predict what they will ask. The other questions and the line that the other details they put there, they are fine. You can sit down, look at them, read them, and all manner of stuff. That's fine. But just get the gist of the main thing you want to put at the back of your mind. Now, you come down to what we call intracerebral hemorrhage. Now, the one we just looked at is subarachnoid hemorrhage. So this is just between, if this is the brain, so in this space here, that's where you see subarachnoid hemorrhage. So if this is the brain, substance, so you can now have bleeding. You can have bleeding within it. Bleeding within it. You call it intracerebral hemorrhage, or you call it intraparenchymal hemorrhage. So this is the intracerebral hemorrhage. Another name is intraparenchymal hemorrhage. This statement I put here, this is one of the few things you take into the exam. So you will look at the diagram they will give you. The cerebral hemisphere, you can divide it into cortex and non-cortical, cortical region and non-cortical region. So look here. This area, I can divide it like this. can divide it like this. Everything within this place, basal ganglia palava here, is going to be the non-cortical region. While all this outer area here is going to be my cortical region. So now this is now your assignment in the exam. If they give you bleeding here, this is going to be cortical. If they give you bleeding where they are putting letter H here, just like this is going to be non-cortical. Can you see? So you just need to check the diagram that will be given. Is it the cortical or non-cortical? That's your first thing. If you don't do that, whichever answer you pick, you are most likely to get the question wrong. And this has nothing to do with stuff. It's just for you to look and pick. That's all. So it's not about stuff. You don't need to understand brain before you pick the correct answer. You just see it is going to look like this. So you just see the blood is within this region. See, you can easily use your eyes to carve it out. This region where you have basal ganglia. So if your bleeding is there, you call it not cortical. If it's just here, you call it cortical. All right. So if you are thinking towards, you now look at it. If you are thinking towards cortical, the next thing is for you to check the age of the patient. If the patient is older patient, what is causing it is amyloid angiopathy. If the patient is a younger patient, what is causing it is most likely arteriovenous malformation. If the bleeding is in the non-cortical region, then I say, what do you think is causing it? The answer is systemic hypertension. That's all. That's all. So, cortical, you go for amyloid angiopathy if the age. So, the story will be there. The picture will be there. And they will just list the option. So, the main thing to look for is basically how old is this patient? Because when you look at the picture, you already know whether you are dealing with cortical or non-cortical. So, you now see that the blood is actually in the cortical. You just check the age. How old is this patient? This patient is 70 years. They now ask that, what do you think is responsible for whatsoever you are seeing on the picture? The answer is going to be amyloid angiopathy. They will give you amyloid option A, AVM option B, systemic hypertension option C. The answer is going to be amyloid angiopathy. So if they now give the same picture, but the patient is young, you are most likely dealing with arteriovenous malformation. If the question is showing the bleeding is in the non-cortical region, so your answer is going to be hypertension, systemic hypertension. So please never forget that. All right. So what do we need to make the diagnosis? Never forget the non-contrast CT again. So you can't be wrong. So what about the treatment? So you just quickly check. So monitor for signs of rebleed, shift, possible herniation. So you suspect the herniation once you are seeing this Cushing triad. So you start suspecting herniation. So herniation is actually a medical emergency. So you quickly treat it. You start with mannitol or hypersaline in all patients, not leaving one, followed by emergency. So this is the first two you do. Any of them, mannitol or hypertonic saline. Then the next thing will now be emergency decompressive craniectomy. So this is how they will now put it. They will just list the story. They'll give you now. See, you are seeing abnormal respiration. You are seeing bradycardia, and you are seeing hypertension. We usually call it ABH, Alexandra Brown Hall in UCH. So ABH, so abnormal respiration, bradycardia, hypertension. They are all related to sympathetic nervous system activation. All right. So once you see that and you are like, this patient, I hope this patient is not already herniating. This patient that is having this, you just see abnormal respiration in the question. You see bradycardia because the pulse rate they are giving is quite low, and you check the BP is quite high, you just be like, this patient, I hope this patient is not hydrating already. So the next thing is, what do you want to give? Best next step. The best next step will now be either mannitol or hypertonic saline. So if you now say, based on this, the patient was placed on mannitol, you now say, what's the best next step again to that? So you start preparing the patient for surgery, and that's all. So, and which surgery is that? Decompressive cranectomy. Then we are done with that. So if you look at it, you don't have many things to rehearse because the foundation is laid for you. All you need to do is to master. So you can pick your book and now flip over it. Like you can flip towards flip your Neuro book. You can flip it in a day. One day, you flip through everything. Because you will just be like, okay, in case they give me this. You can even be saying it out. So if they give me, I'll just quickly check, write it down, or this. Like, whether you solve questions or you don't solve questions, if you don't know, you don't know. Because in the exam, they will always give them. You just bring them out and you now check. So you will see them list them out. You now be like, I don't even know the one to go for. Is it mannitol? Is it hypertonic? They will just list them. So most people will now be confused and be like, this is looking more like emergency. The answer should be emergency decompressive cranectomy. They will come out, but because they didn't use first aid, you just be like, I solved a question like that. I remember it was emergency decompressive cranectomy. So they will pick it again in the exam and they will be getting it wrong. So the exam is all about order. So when you are trying to answer a question, and someone just shout order, order. The way they used to shout it in courts, order. So what will you do first? This is it. All right. You won't be wrong. Anywhere you see something like this, use it. Anywhere, any question bank, go and use it. You will always be getting your answer right. So if they even set the question, you will pick it and you will be happy with yourself. Subdural and epidural hemorrhage. So there is nothing in this that we don't know before. I'm very sure. Is there anyone that when they give the picture of subdural and epidural, the person will be like, I don't know if this is epidural, this is subdural. How does epidural look like? How does epidural look like? Epidural.
Biconcave.
You wanted to say biconvex, right?
Biconvex, rather, biconvex.
Yeah, I agree with you. So subdural is actually what? How is subdural looking like?
Banana shape, precenteric.
Yeah. Half moon shape.
Lovely. So that makes sense. So when they give it, you'll be like, okay, I think I get this. So this is, can you see? You can see this is, which one is this? Which one do you think this is most likely to be? This one is
Epidural.
This is
Epidural.
epidural. So this is now what? Subdural.
Subdural.
Exactly. Exactly. Now let us now bring out. So now that you know you can identify it, so you already know it's not about diagnosis or no diagnosis. It's about now best next step. Now let's look at it. So for the subdural, the way they present is that you just hear usually either very young patients or maybe an infant or something, then elderly patients. So they are the one that usually come down, or someone that used to take a call. They are the one that usually come down with this subdural hemorrhage or hematoma. So the first thing you want to put at the back of your mind is this: which vessel is affected? Is actually the bridging veins. They are the one that this is a venous problem. So vein is affected here. So in epidural, it's actually the vessel that's affected is middle meningeal artery. This is an arterial problem. So if this is venous problem, so it will take a lot of time before the patient will calm down. So this is how the question will now go. Someone had a fall, then they just notice that the activity of that patient is reducing gradually. So then the patient starts sleeping and just starts sleeping. It might be a grandma. The grandma had a fall 4 days ago. So the grandma, now when the grandma fell in the toilet, so we were not there. So they will just say they were not there, that they didn't know whether she hit the head on anything, but she was like she didn't hit the head on anything, that she guided herself. And sometimes I just say she hit her head, but there was no bleeding from any orifices. So however, 2 days after, the notice grandma activity reduces and she has been sleeping a lot. So once you see that, you are most likely dealing with subdura. Just say subdura. Just say subdura. Don't even read the question finish. So whereas epidural, they are most likely going to come down with it immediately. So this is more likely going to be immediate. All right, so that's another thing. Venous blood bridging vein is affected. In epidural, arterial blood is affected. All right, so I've already given you how the history will go. For the epidural, usually they will just say the patient had an accident and immediately lapse into loss of consciousness. Once you see that, just say most likely the patient is already bleeding. So immediate loss of consciousness is the question, because it's arterial blood that is arterial vessel that is affected. The blood will accumulate on time. So, and that's what you see here. There is also another thing you call lucid interval. Lucid interval means clear. So I hope I'm correct. So yeah, so if the lucid interval is just when they are fully aware, they will don't forget that they lapse into unconsciousness. So when they are bringing them to the hospital, they will be awake. Then when they get to the hospital again, they lapse into unconsciousness. So during the admission, sometimes they will be awake, they will lapse into unconsciousness, they wake up, they are lapse into unconsciousness, and like so something like that. So when you see that, you see lucid interval. That lucid interval, you see it in epidural. So when you see someone lapse into unconsciousness, won't you shout for help? Help, oh, epidural. So that's for epidural. All right, so that's just by the way. What about the diagnosis? Don't forget CT again. Non-contrast. Don't go and pick contrast, so it's non-contrast. Then for the subdural, it can be acute, it can be chronic. So I've already explained to us before in one how you will know it is acute. Acute, the blood you will see there will be white like this. It's just going to look white all through. Whereas in chronic, the blood cells will have been lysed, so you will see it's going to look darker. So that's what you are going to see. It's going to look darker. So the same lesion delineation, however, the acute will be bright like this. Why? So you say is actually going to is looking more like what do you call it? Hyperdense. You say it's looking hyperdense. This is hyperdense. So why chronic is going to be looking hypodense. So the chronic might just be overlapping the acute. For those that did one, you will have seen some picture that I showed you then. So now that's just how you differentiate them. What about the treatment, which is where you're expecting their question to come from? So the treatment is surgery. Usually, if the patient is symptomatic for subdural. So like I have fallen before, you have fallen before, but how come no one drag anyone to the hospital and be shouting, oh yeah, this patient fell, let us now be. It's only those that are symptomatic that you want to actually really do something for subdural. Whereas because epidural is arterial, whether symptomatic or non-symptomatic, please, you must ensure that that is actually, in fact, the patient is most likely going to be symptomatic. Anyway, that's for the epidural. So never forget emergent neurosurgical evacuation. Whereas for the subdural that is chronic, if the patient is asymptomatic, you don't need to do anything. If the patient is symptomatic, you need to do surgery again, just surgery. If it's acute, subdural that is acute, so you also need to do surgery regardless of the symptoms. So neurosurgery, if you look at all of them, surgery. It's only the chronic that can be, if at all it's asymptomatic, that you don't really need to do anything. All right, so that's just how we look at them. So you are this for all you care, it might just be surgery or no surgery that they will just test. for all you care, like after reading everything and solving all manner of, so you just ask, okay, what's the best next step here? A, surgery. B, this, give the patient monitor. C, give the patient this. Just shall never forget surgery. I mentioned that once you say key fact, most likely that has been used to answer question before, question has been set on it before. Altered mental status associated with expanding epidural hematoma occurs within minutes to hours and classically include acute loss of consciousness, which lead to lucid interval and gradual loss of consciousness. So with a subdural hematoma, such changes can occur within days to weeks. So it will take a longer time in subdural compared to acute in epidural. What about cavernous sinus thrombosis? Cavernous thrombosis. Cavernous sinus thrombosis. I just need to show you, just for you to have an idea of how the question, not for you to see that, because they can coin the story anyhow, but the pillar and the foundation of the question will not change. If you want to build a house, there is a way the foundation needs to be laid for different kind of houses, or how tall the house will be. The same thing for all these questions. There will always be a premise with which most of them will be laid. That premise is most likely going to be the same, even though the story around them may be different. Now, let me now show you how cavernous sinus will be. Cavernous sinus itself is just a blood-filled collection of venous sinuses that you see on either side of the pituitary gland. So now, what are the common etiologies for cavernous sinus thrombosis? Uncontrolled infection, number 1. Uncontrolled infection, number 2. Uncontrolled infection, number 3. Uncontrolled infection, number 4. Uncontrolled infection, number 5. You now forget uncontrolled infection. Something is wrong. Of where? On the face. On the face. Face is face. Facial skin, orbit, nasal sinuses. Just there. So if a patient has infection on the face that is not well controlled, the patient is at risk of cavernous sinus thrombosis. All right. So what will happen? The infection can easily lead to septic thrombosis. You call it septic thrombosis. Which organism do you want to take into the exam? Staph aureus. Staph aureus. Staph aureus. How will the patient now present? Headache. 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 You will now see something related to these cranial nerves. Something related to cranial nerve 3, cranial nerve 4, cranial nerve 5, cranial nerve 6 deficits. Another thing you will see is orbital pain, edema. The patient may even have diplopia. So now let me summarize it. Something related to the eyes and the surrounding structure in that orbit. Headache too. Then infection. So once you see that, just say cavernous sinus thrombosis. So that is for diagnosis. The next thing is, how are you going to, the story. How are you going to diagnose it? What are the investigations they will test? The investigation, MRI. MRI. This is actually related to a blood collection system. So MRI, so with gadolinium and magnetic resonance phenography. So CT can also be done, CT angio and CT phenography. So they are also often used for diagnosis. So just remember this neuroimaging, either MRI or CT. When they give you WBC, you will see it's going to be very high in the same patient. So if it's not high, that's fine. If it's high, that's fine. The clinical picture is still going to be the same. Now, you now come down to the treatment. You come down to the treatment. The treatment I just want you to remember is antibiotics and anticoagulants. Sometimes they may not mention anticoagulants, but never forget this is the main drug, because most of the time they are due to infection. Once you see it, they just say, what's the best next step? Antibiotic. Best next step, antibiotic. Best next step, antibiotic. What of if the patient is not febrile, there is no infection, nothing there, then low molecular weight heparin. Main thing. So if the question mentioned low molecular weight heparin right from the beginning, I will say it again. You check the question, you are seeing infection is quite obvious in that question. The answer, antibiotic, main thing. If they like, they can go and say plus anticoagulants. Anticoagulants or low molecular weight heparin. So that is when you see infection in the question. You can see it's obvious. You check, infection is not there. You do not see any infection there, but the patient is still having caffeine sinus thrombosis. They now say, what's the best next step? You don't need to go and be giving antibiotic for what is not there. Your answer will now become low molecular weight. Low molecular weight heparin. So now, what they do sometime again. So you can see when you go for low molecular weight heparin alone, when you combine them. So what they used to do in the question again is to make someone to actually list out those antibiotics. So you need to list them out. So what are they? Vancomycin plus ceftriaxone plus Metro. If I told you it's antifungal, there is fungal, this thing there, component give antifungal. So vancomycin, ceftriaxone with Metro. Then if I told you it's fungal, you may want to give antifungal. All right. So please never forget this at all. If I thought the patient has taken antibiotic and they are not seeing any response, possibly we are dealing with abscess, so we want to go and do surgical drainage. All right, so that's that. Let me just show you a question that may possibly help. So see what they put under the key fact here. Procurement of a head CT without contrast before other imaging to evaluate for hemorrhagic or structural changes. Imaging should precede lumbar puncture in light of risk of herniation. Forget that at your own risk. If you think is the key fact is not fact enough, though, you understand yourself better. So let me show you how just for you to have an idea of how the thing may actually come. You have quite a couple of questions to solve. Look at this. 31-year-old. All these questions is not for you to see and cram. No. Just for you to have an idea of how they coin them together. That's it. Not to sit down and cram. No. So why the answers are there. So not testing you on anything. But just for you to have an idea of the way they are. 31-year-old woman is brought to the emergency department because of a severe right-sided temporal headache with conjunctival swelling. So this patient has temporal headache, and you're also seeing something related to the to the eye. They now say, and anterior bulging of the left eye for 1 hour. So that's the eye. The patient has had right-sided purulent nasal discharge, you can see, and nasal congestion for the past 2 days. There is no personal or family history of serious illness. The patient does not smoke or drink alcohol. She takes no medication. She appears to be in acute distress. Look at the temperature, 40 degrees Celsius. Pulse is 105 and Blood pressure is 125/80. Examination shows bilateral ptosis. Can you see? Which is related to third cranial nerve. The pupils are equal and reactive to light. The lateral gaze of the left eye is limited, which is related to abducens cranial nerve 6. So ophthalmologic examination shows periorbital edema and chemosis of the left eye. The remainder of the examination shows no abnormality. The patient most likely require treatment with which of the following. So if you now look at it, you can see the patient is febrile. You can see there is headache, something related to the eye cranial nerves. So you already have an idea. I hope this is actually not cavernous venous thrombosis. You now be like, okay, if that is that, which drug do I want to give to this patient? You give antibiotics and low molecular weight heparin. So you now check through the options. Which one can you see here? So the answer, but don't forget antibiotic basically. So until proven otherwise, because here we can't really see them mention low molecular weight heparin. So the answer is going to be F. So you can apply that to any other question. The picture is definitely going to be the same. So the same thing is here. So if you look here, let's read this last question here. A previously healthy 36-year-old woman comes to the mind department because of a progressively worsening headache for 5 days. So you can see headache here. She vomited twice after waking up this morning. She does not smoke or drink alcohol. She's sexually active with one male partner and uses an oral contraceptive. Her temperature is 37.5, pulse is 105, blood pressure is 125/80. Examination shows Examination shows tearing of the right eye. The pupils are equal and reactive to light. Right lateral gaze is limited. You can see the way they are bringing them here. So fundoscopy shows bilateral optic disc swelling. You can see something related to the eye to optic disc, which may actually be coming from the from the optic nerve. It can just be coming from there or even the raised ICP. So the remainder of the examination shows no abnormality. An MR phenography, which you agree with, of the head shows heterogeneous intensity in the left lateral sinus. Immediately you see that I just said that this heterogeneous intensity, likely I'm dealing with a thrombus. And I'll say which of the following is the most appropriate next step here. So you can see something related to the eye, all those cranial nerves that are related to the eye. You can see headache. So, and coupled with the MR phenography, you are also seeing something there. You now be like, okay, cavernous sinus thrombosis. So you now check. I remember that guy shouting, infection. That we even needed to calm him down and be like, Dr. Vestos, you need to calm down with the way you are shouting like this before you start having hemorrhoid. So that he now kept quiet. All right, with this now, is there any signs of infection here? We can't really see any sign of infection here. The temperature is actually looking okay. So most likely, this is not secondary to infection. Maybe something else is making the thrombus to be formed. So because you can see sign of it, so this is most likely going to be aseptic cavernous sinus thrombosis. So here now, what do you want to give? Is it antibiotic? Do you want to give antibiotic? Because you can see administer intravenous antibiotic here. If you do not read the question very well, someone will rush to this, but the answer is actually administer low molecular weight heparin and dalteparin, and that's that. So when you look at it, it's easy. All you need to do is just to look at what am I seeing, what is the question bringing out. So, and that will help. Dr. Adebowale.
Can I ask a question about the last one we just did now?
Please ask any question you want to ask.
So the MR venography showed basically, yes, isn't that just a sign that there was sinusitis, and isn't that an indication for infection?
This is actually not the sinus that this sinus they are talking about here is actually the blood. not the sinus of all those ear sinuses, not that one. Do you get my point?
Oh.
So this lateral,
Wait, sinus of the blood?
Yeah, for the blood around it. We have what we call lateral sinus that drain blood. So it's actually in the venous system that they are seeing the heterogeneous. So there is actually a thrombus in that sinus. Do you get me? Hello? Hello?
I get you, kind of.
Okay, so we have, let me show you.
I guess what I'm trying to understand is that there's a thrombus, but the point is that it is not infectious.
Yeah, it's not
That's
infectious.
How we it.
Exactly. So it's not, because you can't see any sign of infection there. So come and see the lateral sinus. So you can see, just for you to see the I don't know why it's like this, but don't shall be annoyed. So you can check the better picture where you are going to see the clearer picture of where the lateral sinus is. So it's just actually located laterally. Anyways, so I don't know if this is clear enough to see, but don't mind before I'm not having my glasses on here, but
no problem. Thank you.
Yeah. Okay. So all you see there is that the picture, the clinical picture, is actually basically the same thing. So with what you, just for you to know, is it the battle you are having is, if someone will go for option C, that person will come out and say, hey, they gave me a question on this, I just pick antibiotic. So someone will now hear that and also take it like that. The person will get into exam and not even read the question again. Which has antibiotic. So we've had you. So know when you are going for antibiotic. Know when you are going for low molecular weight heparin. So if I thought they combine them, which should be what they should do, so we should be fine. But in this regard, there's no sign of infection that we can see here. Do you get me? So it just be like there is no increase in body temperature. They are not giving us any wound anywhere, so you won't think towards that. So this is just something related to the lateral sinus. So your answer is going to be A. Can you see? So just look at it like, okay, there is no sign of infection, and I'm seeing, I'll just go for low molecular weight heparin. I'm seeing sign of infection, antibiotics, so which can be combined with low molecular weight heparin. So the picture is the same. That's all. Are we on the same page, or I'm on my own page?
Yes, thank you. Thank you.
What I'm even talking about the other people. So, Dr. Anita, I don't know if you are there or you have left. It's just your that is there. All right, that's fine. So let's see the. So if it's not difficult, just rehearse it. You can basically mention. You can face your friend and be like, all right, for the cavernous sinus thrombosis. So in case they ask this, don't forget though, this is all here in the book. They are all there. Like you can see it, just the way they've written it, you will see it like that. So and that's all. So in the exam, just remember antibiotic and anticoagulant too. You are not dealing with story in case they list the antibiotics. So the antibiotic can list them for you. Don't forget vancomycin, ceftriaxone, metronidazole. So if there are something that are related to fungal infection in the patient, you give antifungal. A very good example, amphotericin B. So look at the coma and encephalopathy. Is it coma? They will say someone is in coma. We will say we don't know. So that's a lie. So we have an idea. So what is that thing that is causing the coma? Dysfunction of both cerebral hemisphere at the same time, or the brainstem. It can make the patient to actually fall into coma. So these are the causes: encephalopathy, electrolyte problem, central pontine myelinosis when they are just rapidly correcting electrolytes and the likes. So that's that. Now let's look at the diagnosis when you see a patient with coma. Best initial test in the exam: glucose, glucose, glucose. If someone lapses into coma now, you won't still be saying go and check the patient glucose. So just glucose. The others are there: electrolyte, calcium, but at least in case they ask what's the first thing, glucose. All right. So the next thing is now to now check, depending on the vital signs, is it normal, the neurologic examination, the pupils, and all those things we did on dilatation. So just for you to have an idea that, okay, is there anything that is going on in these patients? So you just check them whether they are okay. If they are abnormal, so never forget CT. CT is this CT of the head is the test of choice. However, when you are dealing with encephalitis, early stroke, diffuse sonar, so you need to take a step further or forward by doing MRI, because you may not really see much on CT. You now go and do MRI. So please never forget this progression for the test of choice. So glucose, the next thing is the CT. So you can basically say the two things they are possibly going to be testing. Just few things, like say it to yourself. So when they give me a patient with coma, and ask what's the best next step in that question, if they do not give me glucose, so I will just say glucose. Can you see? That's someone that's preparing for exam. So if they say glucose has been done, it's okay, electrolyte is fine, this one, that one, I will. If they ask me for the best next step, I don't have. I mean, right here, just I don't have time for all this. I will go for CT of the head until proven otherwise. So now look at this area. There may be some questions on lock-in syndrome, brain death. So I'll just pick them one by one, just for us to have an idea of. They will describe it. Is the description they will give, then they can ask for what's going on. Where is the lesion or something like that. So lock-in syndrome. So it's more or less like they are locked somewhere. So let me show you lock-in syndrome patients. I know some of you may appreciate it. Others may look at it like lock syndrome. So you may not hear it, but you may just look at it so that you have an idea of, I don't know the one, so that you have an idea of how. So let me first of all tell you what you will see. So you now look at that patient so that in reality, if at all you see someone like that, it makes sense. So they are awake, they are aware, they have their cognitive function, everything is okay, but they cannot talk. They cannot move their limbs. They cannot move anything except their eyelid and eyes vertically. Except their eyelid and eyes vertically. They can only move it vertically. So they respond just by moving their eyelid. So they can blink. So you say, "Are you okay?" They can just say, they can raise up their eyelid. So you have an idea that, okay, saying okay. Or close their eyes and just say, "Are you okay?" They just close their eyes. It shows they are okay. They can't shake their head. They cannot move their finger. May God not allow us to pass through some very difficult situation. It's quite, it's somehow, anyways. It's not easy for them. So they will be there. So can they breathe? Are they breathing normally? Yeah. Respiratory drive is okay. It's on there. So that's locked in syndrome. So when they describe it, the same thing I've talked about is what they would describe. Like the only motion you are seeing is vertical eye motion. Just say lock-in syndrome. Can you see? You just pick one word or two that will give it out, else you will overread. You just be overanalyzing something that is not your field. Leave it for the neuro people. Let them be having the headache. Now look at this patient. So the patient can look down and upward, but cannot look side. They can't do that. Locked in. May we not be locked in our ward. You see, that's what this patient is having. Can blink. Can you see? That's how they do. You say, I'm fine. But they can't say it. They can't say it. So in the exam, just the way you are saying it, that's how the question is going to come. So they will just ask and that's how they will describe it. So let me show you a question. Okay, before I go, now can I say that, okay, where is the lesion? In the pons. That's where the lesion is. Which artery is likely affected? The basilar artery. So I'm not, look at the causes here. The central pontine myelinolysis. So after rapid sodium correction, so they can actually, those pontine neurons, they start becoming dehydrated. So they start breaking down. So what can make them to be dehydrated? The patient initially had hyponatremia. They now give the patient a lot of, what do you call it? Hypertonic saline. Maybe the hyponatremia is less than 120 milliequivalent per liter. So they now give the patient hypertonic saline that will draw water out of those neurons, and they start desiccating, or anyhow you want to look at it. So that's that. Brain stem stroke to affecting the pons, advanced amyotrophic lateral sclerosis too. So now look at it. Look at this question just for you to have an idea. A 67-year-old man with mild chronic obstructive disease is brought to the emergency department by his daughter with the chief complaint of seizure. The patient has had episode of confusion and lethargy over the past week. He complains of some exertional shortness of breath and non-productive cough. His daughter believes that he is losing weight and has decreased appetite. His temperature is 37.2, blood pressure is given, the mucous membrane moist, there is no peripheral edema. Neurological examination is unremarkable. So look at the sodium they are giving here, 117. Rapid correction of this patient's metabolic abnormality put him at risk of. So this will be what? Osmotic what?
Option D.
Option D. So that's that. But let me show you the one for this locked in. Let's look at this. 2 weeks after admission to the intensive care unit for a hemorrhagic stroke, now say a 54-year-old man regained consciousness. At the time of admission, a CT scan of the head shows evidence of intraparenchymal hemorrhage from a ruptured aneurysm. Now say the patient is mechanically ventilated via tracheostomy tube. Now say neurological examination showed quadriplegia, exaggerated deep tendon reflex, and a Babinski sign in both legs. He responds to question by blinking, but neck, lingua, and other facial movement are lost. Dull eye testing shows restricted horizontal movement and preserved vertical movement. This is locked-in syndrome. In your mental status examination, he is alert and comprehend the physician questions. The patient condition is most likely caused by bleeding in a region supplied by which of the following artery? So this is related to the pons. Which artery is supplying the medial part of the pons? What? Basilar what? Basilar artery. Which artery supply the lateral part of pons? Anyone? Which artery supply the lateral part of pons?
Pontine.
Which pontine? I partially agree, but which was the main blood supply? You wanted to say anterior inferior cerebral artery, right? Is that not what you wanted to say? Before you mistakenly say pontine. I'm saying your mind, but probably maybe you don't know your mind. I am saying your mind. All right, so that's that. Anyways, just for you to at least now you have an idea of locked-in syndrome. What is important that they are going to put there. So when they describe locked-in syndrome, you can predict that the question is most likely to be about the blinking, the kind of eye motion that will be preserved in the patient. and not serene. They don't have time for that. So you can revise it within 1 minute or less than that, what they will ask here. So look at the brain death. That's the next one I want to show you. You see, when you say someone is brain dead, so the brain is gone, the brain stem is gone, higher center is gone, brain stem is gone. That is brain. We didn't say spinal cord. This has nothing to do with spinal cord. Spinal cord might be okay, but the brain is dead. So when you see brain death, then all those things are lost. Something related to the higher center, the brain stem, they are no more there. Now look at what I want to show you. Now, before you are now going to say that this patient is brain dead, before you will go for it in the exam, you must quickly check for something, which you don't need to sit down and cram anything. You just check for the core body temperature of that patient. If in the exam, the core body temperature must be greater than 36 degrees Celsius before you say this patient is actually brain dead. If the question says the core body temperature of this patient is 35 and they are suspecting this is brain dead, you don't agree. You want to first of all raise the body temperature to greater than 36 and now check if at all there will be any improvement. You also check for the systolic blood pressure. The systolic blood pressure must be greater than 100. So if the systolic blood pressure they are giving is 85, it does not fit into the diagnosis of brain death. So this what I notice is that this is actually where they revolve, and this electrolyte. These are the places where they revolve in the exam. So they will just give you abnormal temperature and I'll check whether you know what you are looking for. Because if you do not know what you are looking for, everyone will be brain dead when you see them. And what you are supposed to quickly do before the brain will eventually die, you will not do it. And that is to remove the patient from the level of hypothermia. You will not do it. So that is what you can predict what the question will be all about. It's most likely to be related to, hope I know that the temperature must be greater than 36. Hope I know that the systolic blood pressure must be greater than 100. Before I say this patient is actually brain dead. Now, that is for the clinical criteria. When they examine the patient is definitely going to be in coma. Which part of the central nervous system did you say is affected? You say brain and the brain stem. Thank you, Festus. What do we have in the brain stem? You have cranial nerves that help with some reflexes. And because we also have reflex in spinal cord, so we therefore call this one brain stem reflexes. So when you check, because the patient is brain dead, so all those reflexes that are related to brainstem, they will not be there. Pupillary will not be there. Cornea will not be there. Oculocephalic, oculovestibular reflex will not be there. So oculocephalic, let me show you oculocephalic so that you understand it when they describe it in the exam. Oculocephalic, let me show you. Oculocephalic reflex. So you will understand it and be like, oh, this is how it looks like. Don't mind me. So I love to do this so that because sometimes it's actually the video you will remember in the exam and be like, okay, I think this is actually how the oculocephalic look like. Let's see this if it's fast enough. No, not this. I hope it's not the pupils. They are just okay. Let's see if they move the head. Okay, let me.
Hi, this short video is to introduce terminology of eye movement.
Sorry. And this one is shorter. So let's do this.
Oculocephalic reflex testing during brain death examination by Dr. David K. Yerian. We look to see if the eyes can maintain themselves in an attempt midline while I turn the head. So we would never do this examination in anybody who we anticipate or might be worried has a cervical spine injury. But having looked at the chart, we know that this young man doesn't. And so we would turn his head smartly to one side and see if, in fact, there's an attempt to get the eyes back to midline. And we would then do it to the other side. And again, there is no such response.
Oculocephalic reflex. This is sometimes called the doll's eye reflex. With the normal and intact oculocephalic reflex, you will observe that when you turn the patient's head quickly to one side, the eyes will move to remain fixated on one.
So before it continues, so that you will be able to follow it, I know you may not be hearing the sound. Were you hearing the sound?
No.
All right, but at least you can follow it. Yeah, like first we were not following anything, but it's fine anyways. You will remember, so that first show you the video. All right, so all you see is that they stabilize the head first. If this patient was initially looking straight, can you see the patient looking straight? So normally when you move the head to this side, the eyes will look at the opposite side, because what you will tell the patient is fix your eyes, fix your gaze. So you will now move the head. You can look at it. You can, maybe if you have someone beside you, just tell the person to be looking at your finger while you turn the head to the right, turn the head to the left. So when you turn the head to the right, the eyes will be pointing or looking at the left. When you turn the head to the left, the eyes will be looking at the right. Do you get me? So when the question now say they turn the head and these eyes are following the head, the patient is brain dead. They are not supposed to follow. So now follow it.
Flex. You will observe that when you turn the patient's head quickly to one side, the eyes will move to remain fixated on one position in space. In patients with an abnormal oculocephalic reflex, you will observe that when you turn the patient's head quickly to one.
If you look here, as they turn the head, the eyes is following. It's like the thing is not just opposite of whatsoever the normal that we described the other time, or whatsoever you've seen in the video. So that's abnormal one. So when you see something like this, someone that is dead, when you open their eyes and you turn it to the right, you turn the head to the right, you will see the eyes also will be looking at the right. You turn their head to the left, you will see their eyes will be looking at the left. So this is abnormal, because someone like you and I that are alive, when we fix our eyes, we look at it, our eyes can maintain that fixation while we turn the head. Do you get me? So, and that is actually
one side, the eyes will remain mid-position. It should be noted that this reflex can be difficult to assess when there is significant orbital edema, impairing the ability of the examiner to open the eyes, or with significant conjunctival edema, impairing the ability of the eyes to move appropriately.
All right. Now, the last thing I'm going to say under the oculocephalic reflex is that you do not perform it in a patient that is having C-spine injury. It must never be performed. Perform it. In fact, don't dare it. You are like, you can confirm this. Just to be sure that don't ever perform it in anyone that is having C-spine injury. You don't do it. So there is also one more reflex I would love to show you, and that is oculovestibular. So let us quickly check that and see how it looks. So oculovestibular. All right, let's see. Okay, let's look at this one. This should make sense. Just follow the video. So I hope you are seeing what is happening there. So if you look at it, you can see this eye deviating to that side. So that's fine. Alright, so that's just by the way. You can go and so they can do it, repeat it on the other eye. So if at all there is no movement at all, so something is wrong, the patient is dead. Alright, so these are the reflexes they will be talking about in the exam. So when you see, just say brain dead, brain dead, brain dead, brain dead. So no brainstem reflex. Just so there may be the spinal cord reflex may be there. So it may be present, and sometimes that's what the relative will see, and they will be shouting, our patients are alive. The doctor is the one that is not. You see, I can see he's moving this, he's moving that. No. All those reflexes, once they are done, they are not there, they are not there. So there are some ethical issues that surround the brain death that when you are studying, you may see that may pop up. All right, the last thing I will talk about is apnea test. Some people used to rush to this apnea test in the exam. Don't dare it. It's wrong. Apnea test is, you usually make reference to it when all these ones have been done. So it's not the first port of call that you make reference to. So, and what is the apnea test? You just have this no respiratory response to PaCO2 greater than 60 millimeter of mercury. So what they do is that they will more or less like they are going to pump oxygen into the patient through mechanical ventilation. They have a way of doing it. I may be wrong in my complete description, so I've never done it before. So they will just push enough oxygen, then they will remove the they will remove the mechanical ventilation or ventilator from the patient. So definitely the CO2 is going to accumulate, and they should be able to see some respiratory response with that. So in this apnea test, for those that are having brain dead, so they will not see any respiratory response with this, and that's just basically what is going on. All right, so please never forget this: PaCO2 greater than 60, no respiratory response to it. So that's for the apnea test. So let's be guided when we are reading question. So now, don't forget what I mentioned under the oculocephalic. Never forget, because you need to move the head in oculocephalic. If the patient has C-spine injury, you don't do it. Don't go and pick that as the answer. You will be wrong. And that's just what they want someone to bring into the exam. So they can now be setting all manner of questions here. So you can look at this question here. Let me just show you an example, just for you to have an idea of how the thinking is. 34-year-old woman is brought to my department following a high-speed motor vehicle collision in which she was the restrained driver. On arrival, she has a cervical collar in place and is unresponsive. I like, what happened? Her temperature is fine, pulse is 70, blood pressure is 131/76. So you need to pay attention to those vital signs. Let it now be registered as your subconscious mind, because you know that this question is most likely to revolve around brain dead or non-brain dead. So you are already looking at the systolic blood pressure, you are already looking at the temperature. Hope the temperature is above 36, hope the systolic blood pressure is above 100. They now say her pupils are dilated and non-reactive. So they are like, what's going on? She is unresponsive to noxious stimuli. She is intubated and mechanical ventilation is begun. They now say serum concentration of electrolyte, urea, nitrogen are all within normal range. So it's not electrolyte problem. Now say toxicology screening is also negative for hepatitis. No, so it's not a substance abuse question. A CT scan of the head without contrast is showing massive intracranial bleed and a cervical spine injury at the level of C3. So there is C-spine injury and there is intracranial bleeding. Which of the following is the most appropriate next step in diagnosing brain death in this patient? So you now quickly want to do So you want to quickly check for all these brain stem reflexes. Any of them you see. The same reflexes you can peg on all those cranial nerves. You just quickly check on them and be like, which one? Just quickly check. Option A, oculocephalic reflex is there. You also check, blah, 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 blah. Option F, corneal reflex is also there. I have two. I know my answer is between one of them. So you now go back to the question. There is C-spine injury here. So I can't do oculocephalic reflex. So you now go for corneal reflex test. That's all. Whether you trust the answer or you don't trust it, do the analysis simply and go. So when we are meeting in January, you will solve all these questions again by yourself and see. Now look at this one here. An 18-year-old man is on mechanical ventilation after sustaining severe head injury. The patient is unresponsive to various stimuli. Blood pressure is 108/60. So they already say the patient is not responsive. I'm like, is this patient dead or not? I look at the BP. Systolic blood pressure is more than 100. Heart rate is 110. After monitoring the patient for 24 hours, the physician decides to do bedside assessment of brain death. Which of the following can be observed in a patient with brain death? The only one you can observe is the spinal cord reflex. Others, they will not be there. So you need to be very sure of what you are looking for. Others will not be there. Do you get me? So the answer here is going to be deep tendon reflexes. See which test do you think this one, you call this option E? Which test is this? Option E, they are trying to do?
Apnea test.
Apnea test. That makes sense. So this one now, spontaneous respiration at PaCO2. Does this one justify brain death? Would there be spontaneous respiration at PaCO2 of 70 in a patient with brain death?
No.
Exactly. So never forget that. So that when you look at this, before we start solving questions, so let me drop that. So I will have said you should look at this next question and pick your answer for me, just for us to ask, so have an idea of how you've. So that's just that. I think someone wanted to ask a question. Dr. Dibo Ali. All right. I thought you wanted to ask a question. All right. That's that basically. Persistent vegetative state and coma. So this one, for the persistent vegetative state, the patient is awake but not aware of the environment. That differentiates this patient from locked-in syndrome. Locked-in syndrome is also awake, but this one is aware. Whereas persistent vegetative state is awake but not aware. So the eyes are open and closed. They sleep and wake up. The patient does not know where the patient is. So all these eye movements, you won't see them. Voluntary motor ability is not there. So the patient is also breathing, and the cause usually diffuse cortical injuries or hypoxic ischemic injury. Coma, this one is also unconscious, just like brain death. It's also unconscious. Eyes are closed, no sleep-wake pattern. So, So you see diffuse, hypoxic encephalopathy, widespread infection. These are the common causes. All right. So, and that's just for the coma. It's just, this one is just coma. So it's not that maybe the patient is brain dead. Anyway, so when they do all those this thing in the patient, so you are most likely going to see them. They will be there. Brainstem reflexes. Some of them. Now look at this. Now this is now a question you should expect that they've tested in the main exam before. Artificial life support can be discontinued only after 2 physicians have declared the patient legally brain dead. So now what you are taking into the exam is 2. So that in case they try to frame this, you just be like, it's 2 I read now, not 1. So we need another person to also certify to examine the patient. So what is now the treatment? Initial treatment for anyone that is in coma. So stabilize the patient. You can reverse the reversible ones by administering DON'T. D is dextrose, O is oxygen, N is naloxone, T is thiamine. Then whatsoever that is causing it, you address it. All right. It's aphasia. So this is aphasia. So what I'm going to do for us is to stop here for us. If I thought we have the opportunity of meeting again, for those we may be meeting again, we are going to do everything. You solve questions on them and you get used to them. Thank you so much, everyone.